our responsibility was to address the health disparities among Native Hawaiians and create an infrastructure to address that. So Papa Ola Lokahi, the Native Hawaiian Healthcare Systems, and the Native Hawaiian Health Scholarship all work together to try to help address those disparities. And so of the 5 Native Hawaiian Healthcare Systems, we have 3 that are presenting today. So I have Dr. Mahealani Lum from Kealamama. Also have Dr. John Engel from Hawai'i Island of Hui Malama Ola Na'uiwi. And then on Zoom, who's joined us today is Dr. Kapono Chong-Hanssen from Ola Lokahi on Kauaʻi. So with that, I will go ahead and turn it over to Dr. Lum. She'll be the first one that will be talking. So kind of the idea, we kind of organized this presentation to discuss the successes and challenges of each of their systems, right? So, as we all know, each island has unique challenges. And so they're going to be talking a little bit about that and also about, provider resiliency. So I'll turn it over to you, Mahi.
Mahalo, Lisa. Aloha pumehana kako. Oneko Mahealani Lum ko inoa mai aia mai au. I'll start with a story. I had a patient, Mr. W, who was in his 40s and was relatively healthy, no chronic diseases. He worked as a CPA and he had 3 young children, a wife, and lived happily. But in his mid-40s, he started having mysterious symptoms of limp. It was atraumatic. He didn't know how he got it, but he just went on his life, went on raising his kids, and his mobility worsened. Over the years, he started to have other changes, not just to his physical self, but also to his mentation, to his mental self. Started to have rash behavior, abnormal, extreme judgment, started carrying lots of cash around, started purchasing a lot of jewelry and wearing it around. It was very unlike Mr. W. And this was a great change for his family. He and his family didn't know really what was going on with his health, despite visiting with doctors and doing multiple tests. It started to become a critical point when Mr. W started having lapses in memory, started to forget simple words like what a paper towel was called. And then soon he forgot the names of his children, and he's still in his mid-40s. His doctors thought that maybe it was multiple sclerosis, and they treated him, but he did not respond. So that may have not been the correct diagnosis. Mr. W was taken to University of San Francisco, UCSF, to their medical center, and he was finally diagnosed with a neurodegenerative disorder, X-linked adrenoleukodystrophy, for which at that time there was no cure. This was a devastation for Mr. W and his family. His wife could no longer care for Mr. W. At that point, he was unable to perform his activities of daily living on his own, needed full assistance. Sure.
Sorry about that.
Aloha Zoom participants, how does that sound? Shaka. For the sake of the other people in the room here, I'll try not to recap that whole story. But basically, we're going over a case. This is patient Mr. W, who had significant changes to his health, was previously at baseline very healthy, independent, had a family that depended on him. And bottom line is he was diagnosed with this disease called X-adrenoleukodystrophy. So how did the healthcare system support Mr. W following this diagnosis? Well, years ago during that time, there wasn't any cure, especially for how progressed his stage of disease was. He had already lost mobility. He needed assistance with all ADLs, toileting, showering, was bedbound. And in Mr. W's small house, his wife was no longer able to care for him and raise 3 young children who at that time were in grade school. So the family had to make a decision to transfer Mr. W to a nursing home where he was able to receive trained professionals that cared for him. And Mr. W ended up living long past his initial prognosis, almost 6 years after he was diagnosed. And really, it was supposed to be only within a few years of his passing that was expected. And what happened to Mr. W in the end, as you might expect, he did pass from this neurodegenerative disorder, but because of the care and compassion that he and his family experienced from the nursing home, from the healthcare system, just from the support of the community in navigating these challenges, Mr. W's family was able to spend very loving moments, very cherished moments time together in his last days of life. Inspired by the care that Mr. W's daughter received, that little girl in this story, Mr. W's oldest daughter, she had grown up to become Dr. Mahealani Lum of family medicine and geriatrics, who's standing here before you today to talk about resilience. And I bring up this story not to highlight my perils and talk about my challenges, but to kind of show a story of resilience and hope that within each of your stories, you find a reflection of that seed of why you went into healthcare, why you went into medicine. For me, it's very clear that from a young age, I pretty much grew up in the nursing home and learned the compassionate care that was required to care for our people in this community. And so for me personally, that's why I decided to become a doctor, why I wanted to face the challenges that I knew I would have to face in the future, this being an explained disease, and knowing at some point in the future, I might have a family, I might have a son who would also be diagnosed with my father's disease, and just wanting to be prepared, have the knowledge to navigate these challenges and be there for my family. So in this story, with these reflections, we see that resilience lies not only in the journey of going through medical school, going through your training, going through residency, and coming out on the other end. Of course, we build and develop our resilience throughout those trials and tribulations, but really the resilience came from the very beginning. Again, that seed that allowed us to take roots, that foundation that allowed us to flourish into a beautiful tree, a forest, in this beautiful society, this landscape of healthcare, and learning within ourselves what it is that we can contribute to help each other thrive and beat burnout and help our people and heal together. As we continue on our reflections in the other room, if you were able to sit on that discussion, some of these solutions that we talked about in terms of helping our people is creating a pipeline, finding those healers in our community that can rise and become our healthcare providers, reintegrate into our communities to provide. For me personally, that point of departure where I had this interest in going into healthcare, but didn't have the confidence, didn't think I had the resources or the money to become a doctor. It was through community, it was through another physician that mentored me and inspired me that he also had humble roots and was able to become a medical director of a community facility. And without that inspiration and encouragement from someone else in the healthcare field, I do not believe that I myself would have made it. I had a lot of interest in education, maybe even tourism, I wanted to be an event planner, a wedding planner at some point in my career. And if I didn't have that inspiration from someone within the healthcare force, we might not have had me as an addition to this healthcare force. And so I'm really thankful. That was Dr. Ricardo Custodio, who at that time was the medical director of Waianae. The other person that inspired me to go into medicine was my family. It was from my family that there was this urgency that we needed to grow a doctor, to grow a healer within our household. And really in traditional senses, way back when, in olden times, we had a healer in every home. When we think about the workforce shortage, we've got so many sick people in our islands, in our communities, and not enough of us. Yes, providers are leaving, but how it used to be is within every family, there was someone that was a healer. And maybe that doesn't have to mean that there's a doctor in every family or a nurse in every family and whatnot, but there's someone in the family that advocates for healthy living so that starting from the home, that's where health is, not when they come to us in the office or the hospital way down the line. As a part of my journey, the other part that allowed me to build my resilience and stay in healthcare is the money. We talked about how you have passions and desires to do great things, but you don't have the money to do it. Unfortunately, not all can make it. So a lot of thanks to Papa Ola Lokahi for granting me the Native Hawaiian Health Scholarship. It was with this full ride scholarship to medical school that I was able to focus on my studies and not have to worry about financing my education. I could just focus on learning everything that I could about what it took to become a great doctor. And so I thank the scholarship program for also allowing me to reintegrate back into my community. Upon completing medical school and doing my training, I came back home with that remembrance of the impetus, the reason why that I went into the field. I came back home because my conditions allowed me to. And I went to serve in the Native Hawaiian Healthcare System of Oʻahu, where I currently work at Keola Mamo Clinic as their medical director. And it brings me great pleasure and honor to serve my community, serve our Native Hawaiians, our non-Native Hawaiian community in family medicine and in geriatrics. But what we heard in the other room, and a common theme here, is an individual can be resilient, but if you are working in an environment that does not support your wellness, kind of doesn't matter how tough you are. At some point, we may burn out and we will no longer thrive. And so this part of the storytelling is kind of the give back, how I'm giving back to my community in the Native Hawaiian health system, but also how we're helping to transform and think of solutions for addressing these various problems that I've seen from childhood that's still happening. We're still seeing families that are suffering. And while my story was a relative success, it ended in positivity. There are other families where it may end in demise. So when we talk about the health and wellness resiliency of the provider, you can think of an ecosystem. That provider is one organism, maybe a bird that lives in a tree or works in a clinic or a hospital. And that tree is part of a bigger picture, a grove of trees, part of a forest, this great thriving ecosystem. And the health of the ecosystem will help to support that little bird. Looking at each of those levels when we assess how we're doing in the microcosm, that individual, the provider, again, whether you're a doctor, a nurse, a community health worker, a social worker, as a contributing member of this healthcare society, as a provider, just looking inward and reflecting on what's your kuleana, your responsibility. Is what you're doing right now in your return matching up with what you thought it would be? And if not, there might be the solution. Therein might lay some of the answers for how to change, how to align what you're doing with now with what you hoped to achieve when you went into this field. Spanning out from the microcosm, looking at the team or the department that the healthcare worker might be a part of. For myself, I work in a very small clinic. I'm the only physician. I have a nurse practitioner that works 2 days a week, a registered nurse that works 2 days a week, a full-time medical assistant, and also a front office medical biller coder, and thankfully also a registered dietitian. In our community, in the clinic, we really assess and try to support each other to make sure that we can retain these workers. Unfortunately, over the years, like with any other health system out there, I'm sure you folks can relate, there's been a lot of turnover in our staff, more so during COVID. And a lot of folks have been leaving healthcare, again, for non-healthcare work, just because it's less stressful, it's better paid. So what we can do on a small level, things that are within our control, me as the medical provider, the clinic supervisor for the small team, the best that I can do is advocate for my staff, make them feel valued, make them feel that they have room to grow up to their full potential. When I ask my staff what keeps them in this workplace, what's keeping them in this organization, they say that it's the support that they receive. It's that someone believed in them, that they could handle the day-to-day and survive. They knew what they signed up for coming into a primary care clinic in terms of treating a variety of chronic diseases that many of our patients have, so many with socioeconomic barriers and difficulties. It's challenging to be on that side of the telephone, answering phone calls from people who are very stressed out and very sick. And that can feel like a burden to our staff over time. So what I hope to provide with them is enough training, support, one-on-one time to debrief how their interactions have gone. And this is hard in a small practice. You gotta go and see patients. So how are you finding time to reflect with your staff? I think you have to just make the time and use each of those encounters as the teaching point in order to turn it over and again, bring your staff value so that they can feel appreciated and want to stay in it. As we span out and zoom out from the team or department level, looking at the organization or the systems level, this is where a lot of the solutions regarding administrative burden can be addressed. So at our health system, after unfortunately many years of asking, but I'm so glad that they did it, our organization invested in optimizing our electronic health medical record system. So many inefficiencies, so many potentials of the EMR that would have helped the providers to get through their day. Just one burst of trainings, that's really all it took for us to get all on the same page, to be able to see our patients more efficiently and get through some of the questions that we might not have been able to, that are very important to our patients. Our organization did an evaluation of all of our staff, and it's interesting that some of the top things that were most important to our healthcare workers at our health system were the relationships. There was a lot of appreciation and gratitude to the people that we serve, and also the connections and relationships with each other in the team. So this is a reflection on something that my family has taught me. Folks leave a job most likely for one of three reasons, or a combination of those, the 3 P's: people, pay, and purpose. If in your organization there are people you really can't stand, upper management is not very compassionate towards you, not really responsive, then that may cause an employee to leave. And we've seen that over time. Pay, we've talked about a lot in the other room. Reimbursements are just too low. Folks are offered jobs elsewhere that allows them to do their livelihood more comfortably. And purpose. This is where our organization is strong, that we serve our communities, that we develop these strong relationships. And on a grander scale, as we zoom out from the organization level, I also sit on the wellness committee, physician wellness committee for the Hawaii Academy of Family Physicians. So on this scale, we kind of take a look at not just one organization, but a representation of doctors from other systems, small clinics, private practices, hospitals, Oʻahu, Outer Island. And in our assessments of our membership, we saw that similarly, our doctors had a couple of top factors why they keep going. What gets them through their day in medicine? Why do they stay in medicine? It's, again, the relationships with their patients. It's the satisfaction and the honor that they get from taking care and making feeling like they're making a difference in our community. And again, the top factors that cause our physicians to burn out and want to leave medicine are the EHR, charting administrative burdens, prior auths, and the other things that pull us away from clinical care and developing those relationships with our patients. Of course, zooming out from the regional, county, and state level, there's on the federal level, we talked about Medicare, Medicaid reimbursement and how maybe we can leverage groups like this to change legislation to increase reimbursement for us so that we can have more value and payback for all of the work that each of us does. And lastly, if we zoom out further in this forest ecosystem, this landscape, and take a look at our wellness, not just on an individual level, but all the way through all the layers up to the grand ecosystem, our whole community. I've only been in practice for 4 years now, so maybe some of our colleagues here that have been providing care for longer time can comment, but I feel like our people are sick. And I'm not sure if people are getting sicker over time for many reasons, but we talked a lot about provider shortage. What about demand? There's just so much demand for healthcare. But what's the reason for that? A lot of our patients are suffering from severe chronic disease, metabolic disease, cancers, requiring more and more treatment, more time, counseling, more resources that might not be there. And maybe that's what's pulling us away from developing those relationships and getting that joy out of caring for others. It's that there's just so much to take care of when we are embracing and interacting with our patients. So when we think about solutions, here we are thinking as a healthcare workforce, what can we do within healthcare? I think the low-lying fruits, sure, I absolutely agree that money helps the world go round and it helps us do what we need to do. So reimbursement is probably a good low-hanging fruit to really put our money on and try to prioritize in the short term. But I feel like it's maybe a temporizing measure. And maybe in the next 3 years, 5 years, looking forward, what this collective group and other agencies that are working toward physician and healthcare wellness, maybe what we can look towards is collaborating outside the healthcare field to other non-healthcare entities to address the social determinants of health, all those other things that are happening in patients' lives that are ultimately the true source of their diseases. So I hope that by looking through all the levels, we can see and reflect on the resiliency, the strengths that we each have, and bring that together to move forward and help our people down from the micro scale and the provider level all the way up through our whole communities. And I thank you for your time. Mahalo.
Mahalo, Dr. Lum. Love that story. Does anybody have any questions or comments for her? I believe we do have a volunteer that will be walking around with the mic. If anybody has any questions. But I just also want to thank Dr. Lum. She did if you were here this morning, she did the morning pule or the morning prayer. And she's here with us. And then she's also doing a presentation on the geriatric track. So I just appreciate you being here today, Dr. Lum. So we're going to go ahead and move on to Dr. John Engel, who flew in from Hawai'i Island from Hui Malama Ola Lokahi.
Thank you all for being here. Thanks to Papa Ola Lokahi for the invitation to be part of this. And thanks to Dr. Withy and her staff. I messed up my travel arrangements and they got it straightened out for me in the last couple minutes. And to the group that referred to themselves earlier as the Nameless Goons, our volunteers, thank you much, because like with most things, without people like yourselves on the ground, none of this would actually be able to happen. And so I appreciate that. Okay. I think I can do it, but we'll see. So I will apologize for the basicness of the slides. Basically, they're just trying to remind me what I want to say, and not provide all that much in the way of an educational experience. But I am Dr. John Engel. I'm the medical director at Hui Malama Ola Lokahi in the Big Island. And it is, in fact, the Big Island. Our service area goes across the entire island, but that doesn't mean that we can get to everybody across the entire island. When I was asked to be part of this, I said, "Oh, sure, I'll be part of a panel. What do you want to talk about?" And so they said, "Oh, well, physician resilience." And it's like, okay, I'm not exactly sure what that really means. But I'll take a stab at it. And so I did my usual, introverted, medical school left brain approach. And like if I actually click it, And so I said, okay, what is resilience? And I found a couple of definitions. One I didn't like at all because it said you don't change, which isn't obviously the case. But, the ability of a person to adjust, recover, yada, yada, yada. I mean, we all have kind of a general feeling about that. And I did a little research, and not much, but basically researched other people's research. And that research indicated that older physicians, which I figure is probably why they put me on the board, because I've been out of medical school 45 years now, had more resilience than younger physicians. I go, okay. And I got to thinking about it. I said, but, I wonder, is the right thing again. Are older physicians more resilient to our increased experiences and things we've gone through? Or did we just kill or scare off, the guys that are with the less resilience as time goes on? And likely actually a little bit of both. The story took me back to my second day of residency. I was lucky in starting residency. I actually got to start on obstetrics at the hospital, which I actually had done my medical school rotation in. So I knew everybody. So it was actually pretty easy and comfortable for me. But one of my classmates started at the same time, and he hadn't done his rotation there. I came in on day number 2, and I said, "Hey, where's Amos?" And they said, "Oh, he's not coming." He said, "Oh, is he sick?" He said, "No, he quit." I said, "Excuse me? One day of residency, he quit?" He said, "Yeah, apparently he had the laboring lady from hell yesterday, and he just called in this morning and said he was never coming back." And so it's like, wow, you made it all the way through medical school, and you couldn't make it through one day of residency. So I'm guessing that, obviously his ability to have developed resilience during medical school didn't happen too much. But also that I kind of have to wonder, did the senior residents not give him a hand, that day? But I don't know. But basically, so I think there is an issue of people who don't have a lot of resilience. They wind up leaving the field. and that. And, and sometimes that's not always a bad thing, but anyway, so back a little bit to Hui Malama. Like I said, we've been actually in existence since about 91. Hui Malama, basically, we provide primary care. We have behavioral health counselors, nutrition, community outreach. We have a Native Hawaiian practices education section and services that we try to coordinate. And with that all comes opportunities and also comes some difficulties and stresses that I put unique in quotes because they're not unique to Malama. But one of our big issues is, despite the fact we're on the Big Island, we have limited clinical space, even limited in anatomic space. And you think that's kind of a funny thing, with everybody, quitting during COVID, that type of thing. You think offices would be available. And in fact, there is a fair amount of office space available. Unfortunately, there's no dang parking, anywhere. I'm actually driving in the other day and I'm looking around. I'm coming all the way down from Volcano. So I live up from Volcano. And so I'm coming down, I'm looking at like all the empty spaces. I said, how could we be living on the Big Island and not have any parking? But we don't. It's maddening. And because we have limited space, we've had to separate our clinical and our health education personnel, which actually has made kind of an artificial distinction. And we've had problems in being able, in my mind, to really integrate the services as well as I think we would like to, and would service our patients better. Because as a consequence, our community health workers are like all over in the other section. So we're over here, and we lack a little bit of that smoothness. Also, we've had some inconsistency in medical direction over the past few years. I'm probably like the third medical director in the last three and a half years. And so I think they brought me on because I was old, and thus I'm not as likely to go bouncing around. But that hurt the clinic. It hurt the clinic. It hurt the other providers that we have. It hurt the patients and the staff. And so, like with many things, we're working to mend that. And then we have an unusual history of, we actually had a medical clinic a few years ago, but for reasons that are not clear to anyone, the board at that time decided they didn't want the clinic anymore. They just like cut it off suddenly. And so actually we're still suffering with a bit of a stigma in the Native Hawaiian community about, if we go back to Hui Malama, what's to say that the board just isn't going to cut the services again on us? And, we can't go back and change the past, so we're going to have to try to be resilient enough to move through that. And so kind of still brings up the question, are there different types of resilience? I mean, I think there are. Certainly, we have resiliency, personally, in our personal lives, which may not necessarily be the same resiliency as in our professional life. I can wrestle all sorts of monstrous situations as far as patients and medical care and that goes, but I can't stand up to my wife. So I'm glad she's not in Zoom watching me. So I say certainly there's issues there. Then there's issues, of course, our human issues versus our institutional issues. There's a lot of talk actually about institutional issues this morning, because when they're talking about not being able to make payroll, which is not a small thing, keeping people happy, a lot of that actually has to do with an institutional, problem of being able to get proper resources, utilize them resources appropriately, and then be able to expand your services. So that comes from an institutional, standpoint. Now, obviously, if you've got people that don't have a good professional resiliency, they're probably not going to be able to contribute to an institutional resiliency. But institutional resiliency, it can kill you off pretty fast. Certainly can make your life a lot harder. So like, what do I do, when I have to ask the question, is resiliency enough? Probably not. You won't go anywhere if you don't for very long if you don't have it. But you need some help, kind of on the outside. I'm a, child of the 50s and the 60s. I enjoy sometimes watching the look on some people's face when I tell them that when I started medical school, Nixon was still president. And that. And most of the looks I get is blank as in, who's Nixon? Yeah. That's okay. I've got people who don't know what Apollo 11 means either. So frequently, being a child of the 50s and 60s and then early 70s and that, I frequently look to, I'd say the poets of our generation, which basically are the musicians, and the actors and actresses for inspiration and example of things, largely because I'm not poetic enough to provide them on my own. And one of the people, if you look, at least in my opinion, if you look through art and that I thought was probably one of the most resilient people that I ever saw, was a character called Tevye. He was Dairyman from the movie and the play Fiddler on the Roof. Now I'm pretty big, fan of show tunes and that type of thing, which is probably one of the reasons why I gravitate to this. Plus, Fiddler on the Roof is also the first play I ever saw actually performed. But Tevye, poor dairyman, 5 children, all daughters, as he says, which back in 1890, which is about when this would occurred, was not exactly a small thing in regards to the poverty net. But Tevye, through his conversations with God and everything, you could see his resilience and how he would work problems through, work things through. And the whole play, of course, is about the traditions and how we use traditions to try to support ourselves and get us to the next level. But in Tevye's case, they were under attack by the Tsar, as a Jewish community. They were attacked by the Christian section, and that. And then they started having problems with being attacked from within. And the attack was much more subtle. The first attack was, his daughter, instead of being match made, his oldest daughter, asked to marry her childhood sweetheart. They had promised themselves to each other. Oh my God, that was a horrid thing back there. But Tevye was resilient enough. He worked through that. Okay. And he got that. His next daughter decided that she was going to marry an itinerant, Jewish scholar who was obviously destined to wind up in a labor camp someplace because he was radical, and she didn't ask permission to marry. It's just they wanted to bless it. Well, that's another. But Tevye worked his way through. But then he got to the third daughter, and the third daughter fell in love with a Christian outside the faith and ran off and got married. And she comes back to Tevye to try to get his understanding. And he's bantering it back and forth. And finally he gets to the issue, and it was more than he could take. Because he would always say, well, but on the other hand, but then on the other hand. And then he got to point and says, now, but there is no other hand. And what do we do as providers? When we walk in one day and we simply say, I don't know how do I make this go? I don't know. There does not seem to be another hand. What's resilience? Well, I can only tell you what tends to happen with me. Once again, I look for inspiration in a lot of places. In one of my previous lives, I did a lot of drug and alcohol treatment for about 10 years. And there was a popular speaker at that time, Father Joseph Martin, who actually was alcoholic himself, had gone through actually the treatment through the Catholic Church in the earlier days of the 40s and 50s type of thing, and it was very successful. And actually started a treatment center in Hawai'i Grace, Maryland, called Father Martin's Ashley. It's still in existence, although he's no longer in existence. And he was very popular because he was really, really down to earth. He accepted people for what they are, the frail people that they were, and worked very hard at trying to put faith in the things that needed to be done in realistic and terms that could be understood. And one of his things that I remember hearing, and remember hearing this is because the treatment program I worked in, where they played the tape every week of his chalk talk, was right outside my office. So, but Father Martin once would say, he said, people will ask me, Father, does prayer help with a toothache? That I reply, of course, prayer helps with a toothache, especially if said on the way to the dentist. Okay? And to me, what that means is, yes, have faith, but you still have to keep going. You know, you can't just sit there and expect it to happen. And it takes me then, like I say, as a child, although this song came from the 80s, but, to an issue as providers, I think we need to develop resilience. And we develop that over time with our experiences. And admittedly, some people are more lucky than others. I was lucky that I got challenged in my training early and hard by people, though, who believed that I could learn and gave me the opportunity to do that, including making a variety of mistakes. And I availed myself of most of those opportunities. And then worked on. And so as I think about this, this is obviously, as you can see, this is a song coming from the Doobie Brothers. So here I am talking about resilience and quoting a band named after marijuana cigarettes. For those of you who didn't know what a doobie was, that's what a doobie is. And I always, they get this song, 1980, you keep this train a rolling, and it had always stuck in my mind for some reason, but I had never actually looked at it all that hard as to why. And I think in some ways it refers to positions to resilience specifically. And when I get to looking at it, I go like, oh my God, you know, think about how you feel every day. And you have the ability to, I thought about trying to see if I could play it, but unfortunately Mike McDonald has the most number 10 songs whose lyrics you can't understand. So it probably would have defeated the purpose a little bit. And that, but I look at that and, you know, talk about that old whistle blowing that tug upon my heart. You gotta wake up to start my day. And okay, it's a new day. I get to start. But at the same time, you know, there are days when things are just going so hard that you have a feeling you just want to say, you know, screw it. You know, we've done this like forever. I will never see the end of this getting fixed. You know, I'm not going to live to be 500 years old. You know, and so sometimes you have a period where you just want to say, forget it. You know, but they advise that, you know, just because people are complaining and say they don't make it right, okay? Other people don't define your reality for you, okay? And then one of the lines here that I think is really, really important to me is that we weren't born into this life to walk away from everything. So we have to continue to push ahead and give our younger colleagues the opportunity to do that. And as we go down through, it's, you know, point is, you know, we need to keep the train rolling. We ain't going to break down on this highway. But the real thing is, yes, we could sit here waiting, worried, wondering, wishing we were someplace else, someplace other than right here. But baby, we're right here. And so, thank you for the time and your attention. And hopefully we can all develop and keep our resilience going. Thank you.
All right. Mahalo, Dr. John Engel, for that. You know, it's funny, he was talking about his wife earlier, just when him and I were here trying to get ready for this presentation. And he said, you know what? I need someone to take a picture of me presenting, or my wife is going to give me hassles. And I said, okay, I'll do that for you, but I didn't realize I was going to be up here next to him. So Auntie Kathy, my coworker from Ola Lokahi, can you please take a picture of him and we'll send it to him so he can show his wife that he actually did present today? Wonderful story. Anybody have any questions, comments for Dr. Engel? The other question I have for the audience, though, is how many of you, this is the first time you've met your colleagues since the pandemic started. This is the first time I've met Dr. Mahealani Lum. This is the first time I met John Engel because of the pandemic. So it was actually great to finally meet you in person instead of always zooming in. So, yeah. I've met Kapono before, so I don't really care about him. Okay, if there's no more questions, I'm going to go ahead and turn it over to Kapono. And I believe you have the slides on your end and your co-host. Go for it. We can't hear you over here. We can't hear you inside the room. Oh, we're going to get one of the volunteers to come help with the tech. Can I say something, Kapono? Okay. Sorry, if I can't have you speak.
Check 1, 2.
Perfect. You guys can hear that okay? In the back? Is that good? Okay, awesome. Okay, go for it.
All right. Well, I am restarting Aloha Taco. I see a lot of familiar names. I'm sorry I couldn't be there in person. I'm coming to you from my office, my luxurious office in Waimea, Kauaʻi. So I guess I was kind of thinking the first thing. I think there's a lot of, you might want to pay attention to the work environment of your office, but obviously mine is not that luxurious and probably not tailored towards preventing burnout, but this is the reality. We have all our orthopedic braces and everything back here. Right, I heard resiliency, and I have to admit, I kind of cringe, and I think that that's sort of at least the circles of doctors that I socialize with, and some of the social media, I sort of see that reaction when we hear the word resiliency for providers. So I just wanted to talk about, I became the medical director of Ola Lokahi Hawai'i Healthcare Systems in 2018, and I worked there from 2012 to 2018 under another medical director who was a remote medical director, not living on the island of Kauaʻi and working on a pretty limited basis in our clinics. So that was quite different than what I do, and I think I'm hoping that I can demonstrate sort of the benefits of the doctors, the providers, and the staff that I work with of having an on-site medical director. So I'm going to share my screen now. Okay. So when I started thinking through this presentation, Hila Hila, the plant Hila Hila came to mind because I think it demonstrates to me the way that burnout and resiliency can operate. So at least in my mind, Hila Hila can be a pretty beautiful plant with these open leaves that are sort of open to receiving whatever it is. I guess the sun's energy. There are these somewhat beautiful pink purple pom-poms that can be on there. But with Hila Hilas, I think all of you guys probably know if it gets trampled on or touched, I guess, aggressively, then those leaves close down. And the more it happens, more leaves close down. And then you're left with what? You're left with the thorns underneath. And then Hila Hila, if you step on it, it'll poke you. So I somewhat feel like that's kind of what happens to a lot of providers. And maybe you could even look at it over the course of the day, that we start our day open and, I guess maybe more beautiful. And as we start going through some of the trials of the day, we start to kind of shut down those more open, beautiful parts, and sometimes expose our thorns more. And that sometimes ends up being more of what people see of us when we get start to get burnout, or we're not resilient enough to open those leaves back up again for a significant part of the day. So I did put resiliency in quotes, like I said, because a lot of the doctors that I have read through or I see in social media, when they hear resiliency, they get kind of angry, as if it's implying that our healthcare administrators are implying that it's a deficiency within us that is the problem with healthcare and burnout. And I think many providers certainly don't feel that way. And I think related to what Dr. Engel related, if you're not resilient, you probably would get eliminated. It's difficult to get through medical school and residency without being resilient, at least in comparison to what I think the general population is like. But we face challenges, and probably always have, but I think challenges now that have gotten maybe worse. And the term that I've read about is called moral injury. And this literature kind of comes out of discussions about military veterans. So you can think about the trauma that they go through, and a lot of providers go through similar trauma. So I'm on a panel trying to work out a MedQuest benefit for palliative care in the future, and I've relayed this story. This is my sort of moral injury story of the week. But I have a patient who has metastatic gastric cancer, has a mass that's starting to block his esophagus, difficulty swallowing anything, medications, food, liquid, secretions are causing nausea, and he's gone in and out of the ER several times. Essentially, he can't get on hospice because he doesn't want to give up the possibility of getting blood transfusions because this mass is bleeding slowly. So he's gone to the ER for blood transfusions. He would be perfect for palliative care, but his insurance plan does not have a palliative care benefit. And on Monday, after a weekend of ER visits, he came to my office, and we're trying to figure out what we can do. Scopolamine patch, fentanyl patch. So we're working on trying to get those. Well, we're stuck in the insurance approval process. So that's 2 days filling out paperwork to get that insurance approval done for the fentanyl patch. Then we find out currently the only pharmacy on the island that carries it right now is not on par with the insurance plan. So, this suffering that this patient is going through, that I am aware of, our staff are aware of, extended from months, what we hope would be addressed on Monday, all the way until, it might be this morning that But that's just an example, and I think that all of us providers can give examples of those. But it reflects its definition. So it's simultaneously knowing what your patients need, but being unable to get it for them because of constraints outside your control. And another definition I like is perpetrating, failing to prevent, or bearing witness to an act that transgresses deeply held moral beliefs, such as our duty to relieve suffering. In healthcare, those deeply held moral beliefs are the oaths that we put our patients first. And I think on top of this, with the COVID pandemic, you add in also these sort of accusations sometimes that we are actually hurting patients or we're lying to patients. And I know colleagues of mine, in the ICU treating COVID patients who were having that experience, patients angry at them for trying to care for them through COVID. And that just is I think it reminds me of my dad's explanation of Vietnam veterans coming home from the war and then having protesters, angry at them as if they controlled, the decision to go to war and be there. The next part, Seiji Yamada shared this article, Janet Merriman shared this article with me, district health officer here, Seiji's faculty at UH County Medicine. But I think this article that was in the New England Journal of Medicine, or I'm sorry, it was just an opinion paper thing, has resonated with a lot of people. But it's a solution shop of production line. So what are the things in our work that really contribute to burnout? And we have this institutional push towards production line activities that opposes our personal mission, which is essentially to be doctors address symptoms, minimize suffering, and the tension between those, and sort of like the expectation that the provider is going to be able to do all of that in a very short time frame. And then this part, I imagine you guys are familiar with some of this stuff. I remember I came to this conference before COVID, so it must have been 5 years ago or something. And it seems like Mayo Clinic has done a lot of the academic research about burnout. But essentially what I have read is that one of the best things we can do is stay in touch with our colleagues and be able to share about these, this moral injury or the traumatic things or the challenging things that we go through. And so that's kind of what these guys have been doing. And I try to learn from that as far as how to prevent burnout or promote resiliency in the providers that I supervise. So I just wanted to kind of summarize what I think are the things that help with our clinic. One is that we see a low number of patients per day compared to most primary care clinics. And a lot of that has to do with the strength of our administration, the ability to get grant funding, and sticking to our mission. I do think Hawaii, I think we all know this, Hawaii tends to be less productive in the sense of how many patients are seen per day, and I think there are a lot of reasons why that we could get to, but the reality is that, at least in our clinic, a lot of our patients just take more time, and we have the luxury to give that more time, and we have staff to help and case managers to help with all kinds of care coordination needs. But as a result, when you're able to do that, we tend to have experiences with more grateful patients. I've explained sometimes I feel like I'm a mirror, I'm not a light. So if I'm around patients that are kind of like providing light, and a lot of times I think of some of our like some of them I think of them as just shining lights. And if you're around them, you will kind of be brought up by that. And I can be a mirror, if I'm around mostly people like that, I can show that to other people. But if I'm around more like darkness, or I'm feeling more like the hila and I'm shut down, then I can be pretty nasty. Sometimes I show the patients the thorns, and of course, you feel bad about it. But because of more time, I think we get more of those grateful patients that show us light, bring us fruit or whatever things they're going to bring to keep you going, and keep the staff feeling satisfied. I think having the command of your EHR, using templates, and delegating to staff the production line activities, those are ways to take that burden off of the provider. providers. Pharmacy, we have a 340B pharmacy, which has been really valuable for us from a financial standpoint, but also working with our pharmacy director, we talk about how can we make things easier. And, our pharmacy now helps in ways that I wish all pharmacies would, like prior authorizations, or I don't know about all of you in this room, but for me, par for the course from the pharmacy, if something is rejected, to send me a 1-800 number and say, hey, go figure it out. Not usually providing formulary alternatives or why the prescription was rejected, but our pharmacy over time, working with them, they really support our providers by at least making some more effort learning about how to access online formularies and giving the providers better options rather than just a 1-800 number. I think in leadership, policy strengthening, for example, chronic pain patients, when I first started, I don't think we had a very strong policy, and partly because I think our medical director was not dealing with chronic pain patients regularly, didn't realize how much of a burden it was on the providers, especially when you're living in the community and you have to see those people out at the store. They might be angry about whatever has happened, and not having a policy to sort of, I don't mean hide behind, but a policy that takes responsibility for the rules rather than having it all feel like it's on the provider to set the rules and stick to their guns about it. So that's just an example, but use policy to try to cut down on those morally draining parts of care. We have guarded 4 hours of administrative time per week, and I'm hearing when we hire people or recruit people that's really not often the case anymore. I think that's really important for our providers to have some of that time to catch up on charting or whatever they have to do. We have not had a patient portal. We just launched our patient portal, but hiring other providers now I'm hearing, and in the social media communities that I'm part of with physicians, there's a lot of concern about the burden of having to communicate on the patient portal and how much time it takes to respond to messages on patient portals. So that's another one to be aware of. And I think just be careful about the communication that opens up and how much burden or burnout that can put on providers. In recent years, I think we've had a shift towards younger UH-associated providers, and we've also, UH Jackson started the Kauaʻi medical student track, and I think that helps us to attract more of the providers that want to stay in the long run, because kind of like more education oriented and understanding that we're trying to grow our next healers. So I think that's helped maintaining connections with UH. Probably the most tangible thing that we did exactly to relate to the slide earlier about having time with colleagues. We started doing our peer review dinners. We have quarterly peer review, the requirement for our federal grant. So our administration committed to paying for dinners. Essentially, we rotate to fix where the dinner is. We meet for dinner once a quarter, and it's paid for by our company, not the alcohol. Usually I end up paying that bill if people want it. But it's just, we have to get a little bit of work done, but it's mostly social time for us to get together and share our stories, funny, sad, challenges, talk about the EHR, find out, best practices, ways to make it work better, and just really stay connected and have that feeling that we're a team. And then work schedule flexibility as much as possible too, especially with COVID. We had providers who needed to care for their children, and so we tried to be flexible whenever we can. And really, I think that's what's helped to make it feel like it's a team thing. We're all in the trenches together, and then we're willing to try to accommodate people's schedules, try to make things work, because we all have challenges that we face outside of work and inside as well. So those are the main things I mention in my bio. I think part of this mentality came out from being a soccer coach, a high school soccer coach. But I included some of these pictures just to show, when we get recognition, to share it, with all of the staff, try to share it with everybody and really promote that team feeling that we're all in it together. So I hope that's helped, as far as promoting resiliency or preventing burnout in our clinics. But that's the way I thought about it. Those are the steps that I
test. Can you hear me? Okay. Mahalo, Kapono. That was great. Sorry you couldn't be here with us, but mahalo for sharing your office with us. Does anybody have any questions for any of our panelists or guest speakers? As I'm listening to them talk about resiliency, I was thinking about not all patients can be doctors, but all doctors are also patients as well. And so they're human as well. And so I just find it very, it was very nice to hear each of your stories and your presentations. And I thank you for that. And I just want to check in on Zoom, folks. How are you doing? Do you have any questions, comments, feedback? Yes. Oh, sorry. Okay. I'll come down to you.
Hi, my name is Ellen Owai. I developed the Certified Peer Specialist program with the Department of Health, Adult Mental Health Division, back in 2009, before 2009. But I really like Dr. Kapono's comments about, we're called peers, but he calls them colleagues. And it is sharing our experiences with each other. And even now with physical illnesses like diabetes and stuff, just to have people to talk to, that's the most important thing. And yeah, everybody has to learn to talk story with each other. And yeah, I'm glad that he was able to write it out for us. But I agree with everything because we're trying to follow a model that is not adaptable to our culture. And I trained in Michigan and Georgia, and all they had was black and white. And yeah, I developed the third program here in Hawaii, but it was all based mainly on culture. Our group is different. We think differently. We have different morals and beliefs. Which does not come out now. But I was terminated because we were the worst state in the nation at one time for mental health until Dr. Hester came from East Coast and changed everything with the community centers and everything. But, I knew once he left in 2008, I would be terminated. And my program was left to people who really didn't care. Basically it was all about money. So yeah, and the comments made on the this morning's plenary, it was basically about money, but they don't realize that our culture, our islands, you have more than that. You have the people, you have the aloha spirit, you have, just the appreciation and gratitude of everybody. So I just wanted to comment. Thanks.
Mahalo. Anybody else? Oh, go on to that. So the question was from Zoom, how many providers that have burned out have returned back to being a doctor? Go ahead.
I just have a comment on that. I'm Irene Carpenter. I'm the CEO of the... Oh, sorry. I couldn't hear it.
Go ahead.
I'm Irene Carpenter, the CEO of Hamakua Kohala Health, federally qualified health center, and we're seeing, like everybody else is, a huge amount of burnout of very experienced providers who've just thrown their hands up and said, I can't do it anymore. And this constant insistence, I'm glad you're talking about it today, that it's the provider's job to be more resilient and to figure out how to do more and more and more and more. It's not. And I think as a CEO, what I'm looking at is how can we help the providers do what they were trained to do, which is less of the administration and less of the checking boxes. And so when you were talking about provider burnout, one of the things that we've been looking at is local providers. I'm from the Big Island, who are, they're 55, they're 60 years old, and they're burnt out, and they're saying, I'm going to retire. Too early to retire, please don't. So what we're trying to do is offer them the ability to not necessarily have to run a private practice and do all of the huge amount of work, including billing and cleaning the bathroom and hiring the staff. And we've seen providers, I've had at least 6 or 7 of them in the last couple of years, that have come to us at the community health center and said, I'm closing my private practice down. I can't do it anymore. It's just too much. They're still wonderful doctors, but they just can't run the business and be a doctor. They're 2 different things, and they're both real jobs. So we've had some providers close their private practices and come to work for the community health center. And that has worked out really well for us. It may not be the answer for every person in private practice, but since, what we do is provide the office and the EMR and the computer and, all of the back of the house stuff. You come in, you see your patients, they're already scheduled. We don't interfere with your clinical, interventions with the patients. And that has helped for several providers not to close their practice down and leave, patients without doctors. And using that model, and because there's such a need in the community, we have grown from 5,000 to almost 11,000 patients in the last year. So those people would have been left without doctors and scrambling on the Big Island looking for them. So not the answer to everything, but it is a way to help those people that are in private practice that just can't do it anymore. It's too hard. And they're trained, they're good providers. We want to let them be providers and provide the support that they need.
Mahalo for that. How much time do we have? Can we take a couple more questions? Okay, we have, and we're supposed to be done at 11:45. Okay, maybe one more real quick, and then someone in the back there? Yeah. Sorry, but I believe they'll be here for a couple minutes after this, so yeah. Okay.
Thank you guys for sharing all of your knowledge. My name is Kaimalie Kane. I just had a question about, or like, what you would say to an up and coming young person going into medicine, how to continue to be resilient or hold on to that passion for medicine and providing. Any advice?
Yeah, thank you. Yeah, holding on to your passion in some ways is what it's about. And there are days it's a heck of a lot easier to do it than others. Part of it comes, I think, as we get older. And so there's not something I can actually tell you as a young professional that'll flip the switch so you'll be ready then for the rest of your life, because it's an internal switch that has to flip with time. And part of the passion, I think, or part of persisting has to do with some expectations, including expectations in yourself. And there's a question that came up in my mind at one point, and neither one of these answers I don't think is the correct one either way. But I reached a point in my life trying to decide what I was going to do. I had to make a decision if I was going to ask medicine to serve me or whether I was going to serve medicine. And as a consequence, in serving medicine, of course, is serving the patients. Now, when you do that, of course, there are sacrifices you will make either way. And there are times that I have wondered if medicine shouldn't be like the priesthood, but that to some extent would be an old person's, view of some of those things. Certainly it would make life a little simpler sometimes. But I would think you try to find your passion where it is. And then there's different ways that you can do that. I've basically distilled my life down to, I have one basic mission in life. Try to figure out a way that I can make the patient that sits in front of me, their life, just a little bit better that day. That's all I got to do. Okay, and over time, that will add up. Talk to people. Talk to the patients especially. How is this affecting your lives? Patients aren't commodities, although we tend to treat them that way sometimes. And it's amazing what humanity will do for you.
Mahalo, Dr. Engel. So mahalo everyone for joining us today. We are over time. I believe Dr. Lum and Dr. Engel will stay here up for a couple more minutes if you want to come and ask questions. So I believe we're heading into lunchtime. So mahalo everyone. Mahalo for those joining us on Zoom. Aloha, I'll talk to you later.
I'm Bianca Frogner. I'm your first speaker for today in the session called House Poor No More, Disrupting the Difficulty of Finding a Home in Hawaii for Health Professionals. It is an honor for me to be here today. I am accompanied by our lunch keynote speaker, Len Nickel. So I'll be starting off first and then handing off the microphone to him. Again, thank you so much for having me here today, and I hope everyone can hear me okay in the back. Yes? Okay, great. And hopefully folks online can also hear me. And just as a reminder for anybody, the slides are available online. So especially those joining us online, if you can't see my slides, they're there. So just a real quick introduction. My name is Bianca Frogner. I'm a professor at University of Washington in Seattle. I direct the Center for Health Workforce Studies, which is housed in the Department of Family Medicine and has been there for a little over 20 years. We are not physician specific in our work. We at the Center for Health Workforce Studies, we examine a number of health professionals nationally, and so we really care about a lot of issues around career paths of our healthcare workers and dive a lot into the who of our healthcare workers. So it's an honor today to be able to share a little bit of some work and building off some of that that we've done in the center around understanding who how transportation and commute patterns kind of relate to housing. And then I'll be handing off this lecture to Len, who will talk a little bit more about the actual solutions, because I'm a little better at identifying problems, which there are many. So I'm going to start off here. If I can. Be able to move in any direction. Oh, there we go. Moving for that. Okay. So this is just a quick a snapshot of something that we have actually on our website. We've been at the Center for Health Workforce Studies, and we've been looking at data out of the American Community Survey. The American Community Survey is basically the long form of the census. It's one of the best data sets actually we have available nationally that helps us monitor what our healthcare workers look like, including all sorts of personal information, such as where do they work and where do they live and commute patterns and things like that. And so we've been spending a lot of time with that data. We have an interactive map where you can kind of get a sense of where people work and where they live. And really the bottom line story is that about 10 to 20% of healthcare workers nationwide really do not live and work in the same neighborhood. And this is including here in Hawaii. However, what's really challenging is that we really finding out where exactly people work and where people live here on the islands is really difficult, because we cannot disaggregate at a very detailed geographic level where people are working and living. This is one of the challenges of having public data. But I'm sure that it's probably true here as it is elsewhere that many people do not work and live in the same community. Many of our healthcare workers on the mainland drive to work, and I did look to see what it was like here in Hawaii to see what percentage of people were saying that they drive to work versus taking other forms of transportation like subways or bus or ferries. And it is the case that here on the islands that we do have see that healthcare workers, and this is across all the different kind of professions, certainly do drive more often than in the mainland. There are some limits in terms of how we even think about commuting and how these questions are asked, because they really, as a respondent to the survey, you really only pick one option in terms of how you commute. Now, personally, I commute by many forms of transportation, and I'm sure many of you do too. I take a car to a ferry to a van pool, and then I walk. So my commute is about an hour and a half each way. And personally, I do live on another side of the water than Seattle, Washington. So I do have to cross that body of water. But when I think about how would I respond to such a question as this, I'm not so sure which one of the many forms of transportation I would answer. So it is important for us to understand how people are getting to and from work so that we can understand what are the available modes of transportation even close to people in terms of where they might live. And that's why I'm kind of emphasizing this kind of point that people work and live in different places and they take different forms of transportation. And I think one point in particular is that what we notice, at least on the mainland, is that, while cars are certainly an option for people who might have the ability to afford a car and afford high gas prices, a number of our healthcare workers, particularly in aid and assistant positions like home health aides, nursing assistants, medical assistants, oftentimes rely on public transportation like buses and trains and subways. And when I think about here on the island, I notice that while buses are a possible form of transportation, I notice that there's a subway line that looks like it's being built between here and at least the airport. And I imagine this is a conversation here is, what are the other forms of transportation people might be able to take? Because that does dictate what is the available housing supplies people would be able to take advantage of if there aren't houses here locally. And I do want to note that it does take people on an average, healthcare workers on average, about 24 to 30 minutes per day, I think this is each way, to be able to get to their place of work. And that's not an insignificant amount of time. It's not like people necessarily work within a 5-minute walk away from their job. Now, we do know that housing is a limiting factor for both rural and urban communities. Now, I know we talk a lot about that in urban areas, but it does certainly, it is an issue in rural areas. And one of the ways, at least in Washington State, I just want to point out in terms of how we've understood housing as a limiting factor is that we actually survey our employers, healthcare employers in the state of Washington on a fairly regular basis through something called the Sentinel Network, where employers kind of tell us what are the challenges their healthcare workers are facing and why they're struggling with vacancies and shortages. And through our Sentinel Network, we do often see housing mentioned oftentimes as a factor for employers in both rural and urban areas. Now, the issues are slightly different based on if you're in rural versus urban areas. For urban areas, it is oftentimes the cost of housing that is an issue. In rural areas, it's less about the cost of housing, but it's more of a neighborhood factor. So the house might not be located in a neighborhood that has like the best schools, and on top of that, just even the cost of housing relative to their pay might not quite equate. So it is an issue for both of the areas, although the underlying motivating factors are slightly different. I did do some mining of the American Community Survey to better understand what home ownership does look like for our healthcare workers in the state of Hawaii and compared to the rest of the U.S. And it does seem to be the case, at least in this survey, although it is a little counter to, I think, what Len mentioned earlier, which is that, and maybe it is the same, just maybe a slightly different segment of the population that I was looking at, is that healthcare workers in Hawaii, all healthcare workers, are a little bit more likely to own a home compared to other healthcare workers across the U.S. Physicians also are slightly more likely to own a home compared to physicians in the rest of the U.S. However, there are a couple of key things to really note, which is that all healthcare workers in Hawaii are a little bit less likely to be mortgage free, and that's even the case even for physicians. And then when you actually look at their monthly mortgage is about 60% higher for all healthcare workers in Hawaii, and for physicians it's about 30 to 40% higher than the rest of the U.S. And then among those who are renting, the monthly rent for all healthcare workers here in Hawaii are paying about 60% also more in rent monthly compared to workers outside in the rest of the U.S. And physicians also are paying higher rent. So both mortgage and rental payments are higher here in this state. That might not be so surprising, but it is, I think, particularly notable that those who are outside of physicians, so these are your nurses, your medical assistants, etc., they are paying 60% more higher. And these are probably those who have slightly less wages than the physicians. So I think that's just an important thing to note. So what are we doing about this? As Len spoke about earlier today at lunchtime, I mean, we have to invest in housing, and this does take partnerships. And it is worth noting that in several cities, smaller communities around the country, they're trying to get creative. And one of the things that kept popping up is the use of motels or rundown motels and reconfiguring them into some kind of workforce housing for those who need it. So creating affordable housing. So in the Seattle area, affordability of housing is certainly a problem. And so a town called Anacortes, which is a little bit north of the city and close to a series of beautiful islands up there, not quite as beautiful as Hawaii, but nonetheless our version of islands. They've turned in a motel there into some kind of workforce housing. A couple ski resorts out in Colorado, in Breckenridge and Summit County, they also bought a hotel and made these into workforce housing. Now, specifically in Nantucket, we saw actually that a hospital bought some duplexes and made that into employee housing. And in Miami Beach, there is a discussion about building some new housing for healthcare workers. And I think what's worth noting is that in all of these examples, while the one that I'm mentioning here that says hospitals are buying duplexes, that is clearly within the healthcare realm, all the other examples named healthcare workers as one of their target audiences for why they were buying up and developing these kinds of units to become houses for healthcare workers. Now, the specificity around how they were able to acquire it, or how at the end of the day, what's the average rent, or if there's any opportunity to ever have equity in these places, that I did not see specified, but I did find it interesting that this is certainly being discussed. And actually, one of the leading groups that tend to have these kinds of discussions are workforce development boards. And every state does have a workforce development board that's funded out of the Department of Labor. In Washington State, we are very much an active partner with our workforce board, where they have a healthcare-specific group where we discuss healthcare workforce issues. And those development boards are ones who bring together a number of stakeholders from all sorts of entities to think about how we can support our healthcare workers. And they're somewhat behind some of these discussions that are happening around these other places around the country. So with that, I'm going to hand it over to Len so he can talk a little bit more about, well, what can we actually do? How can we actually make some of these changes happen? I do welcome you to check out our Center for Health Workforce Studies. I don't do this work alone. I do this work with a number of other people, and I just want to acknowledge their work behind it. So thank you so much, and I look forward to the discussion later.
Okay. Well, thank you, Bianca. And we'll try to keep this brief because we certainly think this should be interactive as we go forward. Can you hear me okay? I picked a picture because I like the monopoly metaphor, because you may remember at the end of the day, the number of houses and hotels in monopoly is limited. And at the end of the day, you might have to bid them up, and that's kind of where we seem to be. First thing I want to say is it's not just a health workforce problem. We basically, you can't see the timeline there, that's housing starts for 1,000 households by year, and they have it sort of by decade. We stopped reproducing our housing stock about 1980, and we almost came back to doing so about 2009. It fell back down, and we're now about 3.8 million units short in the United States for housing stock. not just a Hawaii problem, and it's not just a healthcare workforce problem. One study that is from which I took this wanted to be clear that one of the main reasons there seems to be this huge housing shortage across the country is local zoning and land use restrictions. I do not know how important they are in Hawaii. I hope you can tell me that in the discussion that follows. But essentially, the deal is a lot of places say you got to have a minimum lot size, and a lot of places say it can only be single-family housing. And of course, at the end of the day, when you think about it for 30 more seconds, the people who benefit from that are existing homeowners, and their housing values are, they think, driven up by those provisions, and that's where you get very strong opposition to relaxing those provisions after they go into place. So the trick is don't let them go into place in the first place. If it's too late, then you're going to have a political problem. But at the end of the day, that's the economists who look at this stuff most, I'd say, closely say these two provisions are very important in perpetuating a housing shortage around the country. Now, what's kind of exciting in my view is what Bianca started to talk about, some examples. Employers have figured out if they don't supply some kind of housing solution, they're not going to be able to attract workers. And this particularly became acute during the end of COVID in resort and vacation kinds of places. And so in the Catskills and Poconos and all those kind of places, they figured out we've got to supply housing in a way we never did before to get workers to come back and go to work. And so that's really what's going on around the country. And so the housing crisis and the labor shortage, which I'm sure you've heard, the Great Replacement and the Great Resignation, all that stuff, that's going on. And employers in particular, have figured out housing affordability and wages are deeply linked. And if you're going to get people to come back and work for wages close to what you were paying before, you're going to have to make housing affordable as well. And so I'll just say what a number of employers are starting to talk about is thinking about solving these two problems together, that is your labor shortage and your housing shortage at the same time. So some specific ideas for Hawaii, obviously, and I assume this is done now, but maybe not. If not, it ought to be done pretty much this afternoon. Every healthcare organization of some size should have a housing assistance coordinator. There are a lot of programs, federal, state, even local, that folks don't know about that you could be eligible for, and I'm no expert on them. I'm happy to talk about the logic of some of them, but at the end of the day, there's lots of ways to get subsidized housing or subsidized access to housing if your income is low enough. And while that won't be relevant to physicians per se, maybe not even nurses, it could be highly relevant. There are a lot of those folks listed on that chart you couldn't see from the Hospital Association that had medical assistants and phlebotomists and all kinds of med techs and stuff like that. And I would say if you want to really get serious about solving the problem, you're going to have to think about multifamily construction and some kind of sliding scale rent or even rent to own kind of options, which, by the way, is the way most of the world was constructed, but not so much the way the American image of itself, the American dream, tends to be. So I mentioned one example before about these shared equity solutions, and I will go through some of them in a little more detail right now, and then we want to open it up to your questions and discussion and ideas. But essentially what shared equity is about finding a way to reduce the down payment and or the monthly payment in exchange for sharing the equity in the property. And if you think about it, it's a way to enable purchasing that couldn't happen otherwise. And you could apply it to almost any population. But the fundamental goal is to reduce the down payment and or the monthly payment, and typically both. Because if you reduce the down payment, then you reduce the mortgage you have to finance. And if you reduce that, you reduce the monthly payment in of itself. Also, if you reduce the down payment, typically you can get a lower interest rate because the amount you're borrowing is lower, et cetera. So there's sort of a number of different sort of piggyback advantages of doing this. I mentioned Stanford was the first to do it in the United States in the 80s. A number of universities do it now. And if you think about it from a university point of view, right, doing it for a tenured faculty member is zero risk to the university. And you allow the university to, in essence, participate in the housing market. So it's a good investment for their portfolio. And at the same time, you're making it possible for faculty to actually live near the campus, which a number of places actually think is a good idea. So that's why it's sort of win-win. And so if you think about it, if it's true that way for universities, why is it not true for insurance companies, hospitals, et cetera? Now, there's a program called Landed.com, which was, it's a for-profit thing. It was created to target these kinds of shared equity arrangements for teachers. You know, one of the populations that has the most difficulty finding affordable housing, particularly in urban areas, is teachers, because we don't pay them enough, of course. And Landed.com, it's interesting, when I first put these slides together for Kelly, and that was, I don't know, May, when she talked to us the first time, Landed.com was going strong. Since then, apparently, there's been some interest rate increases by the Fed, which have driven up what Landed.com has to pay, and so they now have everybody on a wait list. So Landed.com, you should go there and look at it, because they have a number of different projects and products, and you can see what they've done. And again, those kinds of arrangements, in general, in the shared equity world, can be made applicable to any profession or any kind of target group. There's another interesting innovation that I think has a number of appeals for a Hawaii context, and that is what's called community land trust. And community land trusts have been used by cities essentially to take public land and have housing on it, right? And essentially what you do is you sell the house to your target person, be it a teacher, fireman, nurse, whatever. You sell it to the target person at, let's just say, 40% below market. All right? And you, in essence, allow people to enter the housing market at way less cost to them than the pure market rate would require. And the trick is, then your requirement is to resell it whenever you resell it 10, 20 years later at 60% of market again. So you, in essence, create a permanent affordable housing stock that way, and you start with public land. It's something that cities have done in various parts of the country, and something, given the amount of land y'all may control, that could be a very good solution for Hawaii. I'll close with this last little example, and I didn't want to get into the truly gory details, but this is a simpler version of a shared equity arrangement. This example comes from Lending Tree. And by the way, these shared equity things are not just university type things. Real banks, real financial institutions have entered in them as well, because they have come to see, again, if the borrower is fundamentally credit sound, but they just can't pay these ridiculously high prices right now, well, then enabling them to get into the market at a lower price point may make it mutually beneficial for everybody. Remember, the world's not zero sum. So there are private examples of doing this independent of an institution which may have some more publicly oriented purpose. But the basic example I want to walk you through is, imagine the home costs $200,000, and I realize that's not realistic for Hawaii, but it's America, so let's pick something out of Alabama. So $200,000 is the housing price. The buyer might put up 10% down. The shared equity lender would put up 10% down. So they both put $20,000 toward the $200,000 purchase. That gets you, if you're doing the math, a 20% down payment, which will typically get you a lower interest rate, right? And it can a 5% down payment. So again, that's going to be mutually beneficial. The mortgage lender still is loaning $160,000, right? So, and again, the mortgage lender could be a completely independent third party. It could be somebody who's also doing the equity part. But then look in the final column in the future home sale. So suppose 10 years from now, whatever, you sell it for $300,000. And the buyer who put up 20 would net 110, right? Because they get the 300,000 sale price. They have to pay 30,000 to the shared equity lender. The shared equity lender gets their 20,000 back plus 10% of the appreciation for another 10,000. And there you go. So that gives the buyer a great return. It makes the housing market accessible to folks, and that's the friggin' point. That is the fundamental idea, to make the housing market accessible to people who would not otherwise have access to it. And again, you can play around with how much of it is the third-party mortgage lender, how much of it is the institution, how much is the equity share. But the fundamental principle is right here. You allow people who couldn't otherwise enter to enter the housing market and thereby make this home more attractive to them than it would otherwise be in the current configuration. So that's our story. That's pretty much the set of examples I know of. There may be others y'all may know about, and I think we'd be more than thrilled to take some questions. Are the chat things coming in to us here? Maybe I should take it from you. Good.
So I was asking if you could rattle off a list of the kinds of institutions that could put up this kind of equity, especially in a rural community where I work on neighbor islands where you don't have large medical groups with large numbers of employees. You mentioned banks, and so my second question with regard to banks is banks in Hawaii tend to be rather provincial, and I can't say that they wouldn't do this, but would there be an issue with a bank that already has such a history on the mainland doing this in Hawaii?
And you can hear this, right? This still works. So the question was, who would be in a position to put up this funding, and could banks who are not in Hawaii now come do it? You start with the first. Certainly, financial institutions are natural candidates because they understand the mortgage world already, and there are examples they could learn from even if they haven't done it themselves. I would also observe any institution with a kind of endowment or reserves. So you could imagine an insurer with reserves. They invest in everything, right? They invest in stock market, they invest in land, they invest in other stuff. Why not invest in housing? Again, you can work it out so that they should be able to make the kinds of returns in this investment as other real estate lenders do. But those institutions with endowments or with reserves are natural candidates as well. And then I would say, Jim, it's possible to imagine large employers. You know, I read about this whole notion of stock buybacks and that sort of stuff. It's going on all over, creating cash for corporations, which then turn around and invest it. And there's no reason this couldn't be an appealing investment strategy for any balanced portfolio, which gets you to, geez, what about the pension funds, right? And the answer is yes. Any financial institution could theoretically find this a very interesting and productive, mutually beneficial investment. What's the legality of, let's just say, Lending Tree coming into Hawaii and doing this? I don't know what the rules might be, but I'm certain that if it came to be an appealing option and the workforce, or the committee here, if you will, entertained these kinds of things, those kinds of arrangements could be worked out, banks can enter geographic markets, but they always have to pay attention to the local rules. I know, for example, when I lived in Virginia, my bank was Wells Fargo. I didn't choose Wells Fargo. It bought a bank, it bought a bank, it bought a bank, it bought a bank where I put my money 40 years ago. But anyway, Wells Fargo is the bank I had when I left Virginia. Wells Fargo's not in Louisiana. I called them up when I moved. I said, why aren't you here? They said, well, have you heard of the Napoleonic Code? So there are reasons why people don't go into certain states. I don't think Hawaii has a Napoleonic Code. But they do have traditions, and I'm sure there's some rules that they have to follow. But yes, it's certainly imaginable you could. But what I would observe is, while financial institutions do tend to follow local norms, it's also true when you show them a profitable opportunity about which they may not have known or have not considered, then it's imaginable that they might be open to this sort of thing in a small part of their portfolio. And then once it's sort of seen to be successful, it can be a larger part of their portfolio. I'll just say, no university's backed off from this, and they're all doing it still today because they have to in all these countries.
I just have a short comment. In Hawaii, housing, land is so complicated because land is held by a few entities. We're an island state, so we're very limited just in the land that does exist. And so you see really weird things happening, like at a time when ocean rise and climate change is really challenging us, and we already are challenged in terms of our food source in Hawaii. Some of our very best agricultural lands have been paved over for housing. Okay? So we may have a house to live in if you're lucky enough to afford it, but in the next category 4 hurricane or higher, we could wipe out all of the distribution points for our food. So I think that while the finances could be worked out, there's a larger issue of how we manage our resources overall. So yes, we need a housing coordinator, but I would really like for us to see a statewide kind of, can be really rational about how we use our resources. And I don't know, maybe work on that and come back next year because I would pay to hear you speak again.
I can certainly appreciate that there are geographic barriers to being able to expand housing. And I'll just note that I'm not sure if the better way to go is to say build up, right? But I'm certainly sure that that conversation happens here. I did notice as a casual observer that obviously the high-rise buildings are here and that they're a little less so outside of the downtown Honolulu area. And I'm not sure how purposeful that has been. And it would worry me if that is a direction that people argue otherwise is to go up, but I'm sure that that's probably one way to go. The other thing I will just caution against is that in Seattle, what's been very common is to allow for multiple houses to be developed on what used to be a single house site. So some of the zoning laws have changed to allow multiple units to now be built basically behind a main house. So what has happened is that one might have a main house in the front, and then, I recognize land is quite limited here, but even there, in some of these neighborhoods, land is a bit limited, and people build basically a unit on top of their garage, that as accessory dwelling unit. I'm not advocating that this is a good idea, and it certainly has changed the nature and the character of some of the neighborhoods where people have torn down what used to be a smaller, cute one-family bungalow, and now what has arisen are like 4-unit mini condos. But I will say that has been one solution that Seattle has been trying to implement in some parts. And I just caution that there's trade-offs for that. One is that you do get more people who can now occupy one land but at the same time, it does change the nature and the character of a neighborhood considerably, especially if there's not any oversight in terms of how those construction look. So you have like a mixed use of like very kind of craftsman style house next to a very modern, boxy looking house. And this has been a tension in Seattle. And I don't know that I'm saying this is a good or bad thing. I think but it certainly has been one approach that cities have taken. And if that is a direction that folks in Hawaii do want to take, I would say carefully look at some of these communities, like in Seattle, for example, where this is happening, because it has opened up more opportunities for people to live.
That's a great point, Bianca, and I'm glad you mentioned Seattle, because I'm glad to hear Seattle has reduced the restrictions on multifamily. But specifically on the geography, I totally concur. I mean, everything I talked about at lunch is all about getting everybody in the room. And people who need to be in the room are the people who think about exactly those issues. And I don't know enough to be helpful, but I'm glad to read whatever you send me. So we'll go from there.
No, that's a very astute observation. Like the big cities of Chicago, New York, when you can't go sideways, you go up. And one of the recent changes in the city has done is that they have shared costs with the developers. And what they do is they allow this urban area, like around Ala Moana, if you have a certain number of affordable units, you could build the rest high income if you wanted to. And from what I've seen, from what my patients tell me, you get what you pay for. So when these developers build these mixed units, they kind of try to skimp. Whenever you have this model, they'll try to keep the cost low. And literally, I've heard horror stories of the first 5 floors of a 40-story building where the drain pipes are solid rods. They just solidify. And they're tearing a place apart and they're trying to fix it. You get what you pay for. So how do you incentivize, for them to go with this model, but yet pay enough so you get quality product? Yeah, you get.
The example that comes to mind is even for those who actually spend a lot of money on a house, doesn't necessarily guarantee a good building. I think about one example in San Francisco, which is where I was born and raised, is that there's a very, very pricey high rise that is sinking. It is sinking. I mean, it's leaning and sinking. It was poorly constructed. I think there's a larger housing kind of challenge in terms of how these are being developed. I mean, in D.C. too. I lived in Washington, D.C. for a while, and I know when I was looking for housing, and they're eager to build lots of units to put more people in the district. And I noticed a number of places where the floors weren't quite level or the walls didn't quite meet the floor. And that does speak to a kind of a larger construction issue. I mean, in terms of who is it who's monitoring the quality of the housing. So I certainly agree that you kind of get what you pay for, but I will say that you will see these problems probably across the board, maybe not as obvious, but I'm concerned about rapid growth of housing generally in terms of what that means for quality control and who's actually looking after that.
That new housing requires new oversight. There's no question about that. I would observe that the low-income housing tax credit program has been around a pretty long time, and at least I know some people who are happy with it. Cleveland, Baltimore, and it has to do, I think, with a combination of the particular market need, the configuration of how the incentive works, and the regulatory environments in those particular places. So I think, to be fair, yeah, back when they didn't have low-income housing being built, the regulatory regime here didn't worry about it so much, and now they need to. That may be what I'm learning here, but I think that's
Thank you. Thank you for the discussion. In addition to the first 2 questions, it does sound like Oahu, or maybe the other islands as well, seems to be suffering from tragedy of the commons, limited land resources, and land resources versus agricultural land. One thing I was hoping that would have been discussed was creating residential units that are sold for prices beyond what your average resident can afford, even with shared equity. It seems like a little challenging for your average resident.
Well, you're certainly right. You gotta pitch the level of the shared investment at something that's affordable to the target population you've got. And all I would say is that you're totally correct. If you don't pitch the level correctly, you're not going to get any takers, right? But all I would say is all the shared equity arrangements essentially try to do the following. They try to enable people to buy a house at less than the current market price. And you can set that degree as high or low as you think you need to go, right? And at some level, it really does depend upon, like what I imagine, for what it's worth. You might have one set of houses that would be available to doctors, and they might be expected to put up, 30% or something, and the medical assistants might be expected to put up 10. And so you have a kind of a sliding scale shared equity arrangement. The math can still work as long as you make it affordable and the income of the person can afford the payment that they have to make. Right? So in principle, you can dial it up or dial it down as long as you've got a willing lender and a good credit.
I just want to address, I think one other issue it seems like the islands are struggling with also are a lot of foreign investments in the area, right? There are a lot of people who are coming to buy property and they don't live in these properties. I know that in Vancouver, Canada, that has certainly been an issue in that city. They're not the only one, but Vancouver has certainly experienced an influx of foreign investment for people who don't live in a number of the buildings. And there has been a relatively recent tax that has been implemented on foreign investment. That does take considerable political will, and that is Canada, not the U.S. But it has had a significant effect on the housing market and availability of houses. And maybe there's something on the opposite side that rather than taxing the foreigners who might come in to invest is to alternatively give some kind of subsidy to incentivize or to allow developers to develop targeting local residents. But again, that takes a much more complex local conversation, but it is worth noting that that is a tool that has been used somewhat successfully elsewhere.
I just ran some figures. Can you hear me? Okay, I just ran some figures when you were talking about the shared equity. And one of the things that's a problem for us here in Hawaii, and I think it's to all the islands, is that the cost of real estate is so escalated that even doing like shared equity where you'd be looking at a 20% down payment, most people, most healthcare professionals can't even afford that. But the other thought I had too is when you're talking about developers building, I heard something just recently where they were talking about the best use of building up is 3 stories. And part of it is because of the use of the materials and the use of the land. And they were talking about the housing projects that were done in, I don't know, the 60s maybe it was, in some of the big mainland cities. And they just said that was just such a waste of materials and land and whatnot. Do you want to make any comments on that?
my first thought is, so it sounds like it's from the developers. Um, it does speak a little bit to what are the incentives in place that, get them to be willing to develop. And it sounds like there wasn't enough there. So they're going to say that it wasn't worth it. It didn't quite pay off. But to that first comment about just having the down payment just being even larger than probably a 1 year salary, say, of a medical assistant. I personally care a lot about those assistants and aides who make on average like somewhere between $30,000 to $40,000 a year, and do they even have any opportunity to even buy anything? I mean, that's certainly an issue even on the mainland. And as I heard on today's morning panel, I know Jim was on there too, that there was this acknowledgement that they're seeing high turnover of medical assistants. There's like two or three less medical assistants on staff in many of these clinics. And I know we don't talk enough about what kind of means are available for folks even at that level to be able to live anywhere close to their work. And I'm worried a little bit that combined with the lack of public transportation, there are good options. They're really being pushed out quite far and traveling much longer, and to be able to find anything affordable. And this does just become more of a, I think, as Len said earlier, we have to just have that conversation. And I see that this cannot happen only insularly within the healthcare industry, right? I mean, you have to find other willing partners around the community outside of healthcare to have those conversations. And again, I go to the Workforce Development Board because in some ways there is some public funding behind that to at least bring the people together and have a reason to have this conversation. Now, they are generally more driven by supporting people who want to go on a career pathway of becoming a nurse or a physician, and they have a little less of a focusing on those who become aging assistants. But I like that highway kind of analogy that Len used earlier, that medical assistant might be on the pathway of something kind of better paid, longer term. So all this to say, I mean, somehow there needs to be more of a conversation of also having targeted subsidies for those who make below some amount of money, who work and dedicate their lives to healthcare in particular. I mean, much like teachers also, I think there are some programs out there to help subsidize some loans for teachers out there. And I think healthcare workers at all levels, all the way down to assistants, should certainly be part of that conversation. And I do see that there's a question here on chat, so that someone's asking for, would Hawaii be more open to the tiny house that is more of a recent fad that has become more popular? And the other one I think is kind of answered. So that's more of a question for you all. The tiny house movement, if you're not familiar, is just literally a tiny house. It's almost like a little 1-bedroom studio, but in a house version. Yeah. It's certainly a NIMBY problem, not in my backyard problem. Again, in Seattle, I've seen these housing communities, and they are kind of cordoned off. We have a big tent problem for homeless in Seattle. So, and I know many other cities certainly struggle with this, but Seattle and San Francisco certainly have a huge homeless problem, and so tiny houses have certainly come up as a community, as an option, as a solution. But mostly what that has been that the tent cities have just been replaced by these small houses. So you still have the same social problems that many homeless struggle with, that you need to figure out actually how to embed maybe a social worker in those communities to actually make some of that thrive. And so I'm just saying that I guess these small houses have been kind of targeted towards certain populations which have been homeless. I don't know if that's been worked very well to apply and build small houses for kind of broader communities. I'm looking at just a couple other notes here that came through on chat. One says, would shared equity work in Hawaii? Would shared equity work in Hawaii where existing and sometimes really old single-family homes are selling for a median of $1 million and condos for $500,000? That's kind of been answered. And then someone else mentions here that they had attended an org code training and found out that tiny homes actually cost 2% more per square foot than regular homes. That kind of goes back maybe to the materials comment that was made earlier.
Hello? Yes?
For those online who are listening, the question is about the rising interest rate and what that might be doing for the pool of buyers.
So thanks for that really easy question. I think it's fair to say that I've never seen a 0.75 increase by the Fed either. I think it's fair to say we should take Chairman Powell's words for what they were, and he said, no one knows if this is going to really end without a deep recession. I believe, 100 years ago I was also a macroeconomist. I believe what he's trying to do is to show the markets he's serious about inflation in order to, if you will, wring inflation expectations out of the economy quicker than a deep recession would. So it's a gamble. It's a gamble that might work. It might not. He, in his wisdom, and his board of governors thought it was worth taking. What does it mean in the long run? Well, that's why LendingTree.com, or landing, whatever the thing was. Yeah, the other one is on hold, right? Everything's waitlisted. So, no question, rising interest rates makes lenders pull back, makes buyers pull back, all that stuff. We are talking about a longer run solution where at some level the point of all of it is to get the net interest rate, net payment down to an affordable level for the health professionals and other professionals, other human beings you're targeting. That's why we think it has to go beyond housing. You can't get political support for subsidizing homes for doctors and leave everybody else out. So there's got to be a more, if you will, comprehensive approach. I just think that what the Fed is doing right now is designed precisely, almost like trying to strike with a surgical scalpel the inflation in the economy and try to do it, get out, so to say, lower rates quicker than they would otherwise give to avoid a deep recession. I don't know if he's going to succeed. I sure as hell hope.
Test, 1, 2, 3, test. Hi, hello. Hi. Is this microphone working? Okay, sorry. Several observations. Number one, it is not just restricted to medical professionals. In Hawaii, some of us have this saying that for the Kanaka Maoli, you're not homeless. Hawaii is your home. What you lack is a house. And the other issue is that in the old concept of things, the Hawaiian word for land is aina. So Papa, the Earth Mother, provides this to feed you, to sustain yourself. And that was what aina was all about. But the problem is that in Western concept, this is a commodity. It's like dirt. You pave it over, you cement it over, and you make millions off of it. And the problem that I have with shared equity is that no matter how much you're going to, supplement or whatever this professional, the issue is you're always going to have somebody who's going to want to live here from somewhere who's going to outbid you. You look at Kaka'ako, yeah, they're putting up like 30-story buildings, and like they're going for millions, condominium unit for millions, and even with shared equity, you can only go so far. You're going to find somebody who's going to be willing to pay way more than you are.
You make very good points. I couldn't agree more. And I would say that's why maybe in the Hawaiian context, something like that community land trust idea where that cities have used to basically say, okay, this public land, we're going to build houses, and you will not be allowed to sell at market rates. You can only sell to, if you will, the target class of people, and at a rate comparable to the low market that you got to buy it for. So you prevent speculation, sir, by law. That's the only way to stop speculation. I remember way back when I was young and my son was 4 or 5, we went to Banff, Canada. And Banff, Canada is a wonderful place to visit. They have elk floating through the town. It's quite idyllic. And they had a rule up there. And they set the rule in place because of movie stars moving in and buying houses. They had a rule that if you didn't work there, you couldn't own a house there. And it shut down the movie star market right away. And so I'm just saying, if you want to prevent that external speculation, you're going to have to set up a protected class, which can be done, but it requires law.
Yeah, I was going to comment on your Vancouver comment. They charge a 25% penalty if you sell a property in Vancouver and you're not a resident. And it seems like we could be doing that with people that aren't residents here that have vacation rentals, right? So just to disincentivize mainlanders or foreigners from Hawaii, non-residents, from purchasing investment properties here. The other thing I was going to mention is that when I talked to Bianca and Len earlier, there's really no limit on the equity split, right? I mean, you could have that $200,000 imaginary house and have someone own 50, the equity partner own 50%, and then you're literally getting the house for half price, even though you only own half the house, but you own half the house, and you have the option to buy it later on if you have more funds. Is that right? Yeah. And then I was going to ask this woman a question because you seem like you really have some insight into the agricultural lands and such. Josh Green had talked about freeing up state lands to build housing on. Would that work as a way of preventing loss of agricultural lands? That might be an option then, state lands.
Small test of change. I would look for a place where we could try, to identify land that is currently not in agriculture, that is in an area where we are resource poor. We need more workforce out there. And can we build the housing? Can we build, some of the community supports that you guys have been talking about? Do it on a limited basis and test some of these principles to see how they would work in Hawaii. I would go that route.
Hi. I want to expand the conversation a little bit just to ask you, I don't get to speak to economists too often, how would it change if there was a livable basic universal income?
I mean, that I think could help. I'll just use an analogy where I worry about whether it helps healthcare. So I'm all for raising wages to get to a more livable level. And again, I'll just use Seattle as an example, but this certainly is the case anywhere else, is that there's a fight for a $15 minimum wage. Sure, but it's better than where it is. But just hang with me about like what my concern is, which is that if everybody's wages rise up, it doesn't necessarily help healthcare specifically, right? Because now, I mean, for me, one of my concerns is that now everyone has. It's good for society, but it's not good for healthcare in particular. There's no benefit that healthcare particularly gets because now everybody can kind of move around to different jobs elsewhere. Like what I worry about, for example, is retention. And I think housing we're talking about as maybe a example of a retention issue for people staying in healthcare, meaning doctors and nurses, for example. But just as much as our medical assistants, we need to figure out how to retain them and have them be able to afford what they need here. But when everyone else is also having their wages raised, there's no competitive advantage that they now have as a medical assistant, for example. And so I do think it can help. I just don't think it is the only answer. So I think it's one of many things we should be considering and is useful. My only concern is whether that actually helps healthcare in particular.
Yeah, I would just observe, again, you asked for an economist. So it's on balance the right kind of thing to do. It would probably have the effect of enabling more people to afford more stuff, which in the short run, without increased supply, could actually drive up rent. So I think what I like to think about is sort of all these different buckets. One bucket is how can we increase purchasing power of people, which a universal basic income would do. So would a much higher livable minimum wage kind of thing. How do we increase the supply of stuff we want to make sure people have? And that may be a separate question, because if we don't also invest in supply, you're going to end up with people suddenly crossing the MIT threshold and not having enough housing either, right? And just bid up rents and so forth. So you need to work on supply as well. So what I would say is there's kind of maybe a 4 variable equation here. One is, what is the wage? One is, what is the supply of stuff we want to make sure people have, public schools, etc. Another is, what are the subsidy rates for different people? Because we probably still don't have to subsidize some stuff for somebody, right? And the fourth variable, which we don't talk about much, but we should, what is the tax rate that we apply to people of means? I mean, when you get right down to it, you can either pay people more and they can buy what you think they need as long as you pay attention to supply. You can subsidize people with taxes, or you can use taxes to build the supply. So there's lots of different ways this is all in play. You might have noticed all of it requires serious consultation about what kind of world we want to live in, what kind of redistribution do we think is necessary to have that world. And that's a conversation, in essence, politics is for, but we haven't been really good at having that conversation lately. However, I think this is a place now, and you certainly are at a place in Hawaii where you're having the conversation, just not with all the cards on the table. So let's talk about the foreign investor problem. And by the way, that problem is not unique to Hawaii. We already mentioned Vancouver. New Orleans, where I live, it's a big issue. People coming in, buying homes, renting them out for Mardi Gras and Jazz Fest, rent them out for 3 months a year, pay off the mortgage. You may have seen The Economist, which is the magazine that's published in England, that's very savvy. I highly recommend it. It just had an article about private equity buying up housing all over the country because rents have been increasing, family level rents have been increasing like 25% the last 2 years. So they see it as a huge investment opportunity, just purely moving capital into the market, which just increases the scarcity for people trying to buy their own house. So all I'm trying to say is there are 4 variables in question. You can think about all of them at the same time.
I'll just ask, there's one other comment here that said, if supply increases, so does waste, if not done sustainably, which doesn't necessarily help anyone, including the environment, which I would certainly agree, not disagree. I think that, my feeling from this conversation is that I think Len and I are hopeful in at least sparking a conversation, but we certainly don't have answers. And this is, I think, if anything, an opportunity for us to at least share that these are challenges are certainly shared countrywide. And I think the public good statement that Len really articulated this lunchtime, I think is a good one, because I do think it takes a collective effort to think through as a whole of the healthcare industry to say, hey, if you want healthcare, if you want healthy people on this island, you have to invest in the actual healthcare workers before they leave. I mean, this is a public good that's just, our healthcare workers are feeling burnt out, and it certainly is a feeling that is experienced across the country, that our healthcare workers are saying that they're leaving, they're going to leave soon. We don't see a lot of numbers that would suggest that they're leaving quickly or immediately, but certainly that sentiment is there, and it might show up in other ways, right? Like lower healthcare quality might be delivered over time. You might see reduction in hours, which would certainly have the same effect as losing people. And I think that argument is coalescing, getting a little bit better nationally, and so one can hope that this starts to resonate and that people will actually listen. Now, I'll say one thing on recession. Well, I certainly don't want to see a recession happen. Is that one slight upside of that is that healthcare generally does better during those times. That health spending tends to go up, but more importantly for workers, they have fewer job options actually, and so healthcare oftentimes actually provides a continuous supply of jobs during recessions. So oftentimes I get asked the question of whether or not we're going to see a shortage in the future for any of the professions in this near future, and a recession will certainly change some of the equations. One of it, which is whether or not there are other jobs available for healthcare workers to go to. I'm not saying that's great, because that does mean also that people have to maybe accept work conditions that they may not otherwise want. And while we still have an opportunity to capitalize on this crisis, to say, hey, let's solve something, like now is the time to try to come together. And listening to the fact that you have a governor who has a medical, or a governor candidate, who has that medical background, is certainly an opportunity to kind of raise awareness for healthcare and use them as that recruiter in chief, like you said, or retainer in chief, because really that's what we need to do, and that's what we're talking about here today mostly, how to figure out how to retain the workforce as in recruiting. Just one last comment, which is a note to my comment, which is a recession doesn't allow for healthcare wages to increase or money from the government to increase. Certainly that's the case. It's just mostly the lack of other options. And I certainly think it's worth taking a note in terms of what other industries are doing to try to attract workers into their sphere, because, as others mentioned over there, that low wages or lack of housing, these are not issues isolated to healthcare. These are issues that are experienced across many industries. So it's worth talking to other colleagues across the economy to say, hey, food service, how are you retaining your workers? Hospitality, how are you retaining your workers? Because these are the same issues that we're seeing across the economy. Are there any other questions? If not, oh, there we go. Yes, please.
Aloha. I just want to know what are any action steps that someone listening today can do to get them, for those that are interested in becoming homeowners, what's something that we can do today to kind of mitigate some of these issues, or at least if you're not a aspiring homeowner yet, but you want to get engaged on a policy level or an advocacy level, what does that look like? How can we get that going in the communities that we live in on the island?
Well, short answer is I don't know. I think that, one of the things we suggested earlier was hire a workforce coordinator in every healthcare organization that needs to recruit a large number of people or retain every single one of them. There are a number of different programs. Most of the existing programs for housing assistance are tied to income, but they are available to all comers whose income qualifies. And given the nature of housing costs, I think there's adjustment for that in some of these programs. So it's possible you could qualify for housing assistance right now, and no one in this room or in this city knows it. But there are people who can find that out for you. So that's step one. Find out what's available now. And to do that, you need professionals. You've got housing authorities and so forth who can help you do that, I'm sure. But the second thing, which seems like a natural next step, is to begin having a group meet and talk about solutions. I love this pilot idea. I think that's brilliant. I think the notion of working out a pilot within Hawaii's own structures now, and you could, do it as soon as you have a politician willing to make it happen. Have that pilot come into existence over the next year or two. In the next 6 months, I don't know what to tell you, other than to look for what's available through existing programs, which you can find out, I'm sure, from your local Hawaii housing authority. But those options were created largely, like the low-income housing tax credit program, all the Section 8 stuff, all of that was created for lower-income people in general. And you might have heard this rumor, there's a lot of waiting lists all over the country. Those low-income housing tax credits are allocated to each state based upon a formula, based upon income and so forth. And as I understand it, the developers typically bid for those credits because they can use them to offset profit from more high-rent buildings or high condo-type buildings. And there's a shortage of those credits. That is to say, they bid for these things in every state. There's so many profitable opportunities to offset. So there's a shortage in how to solve this problem.
I'll just add that this is a great group. I mean, you're here in this room taking your Saturday to talk about workforce issues, and it seems like there's an opportunity to create some subgroups to tackle some of these complex issues and figure out how to find shared agendas across different health professions. And I think housing is certainly one of these things that is a shared concern across multiple occupations, and figuring out how to get some of these state medical societies together to advocate for some solutions or come up with a menu of solutions is at least one step forward if that's not already happening. Because I think with each health profession going it alone is not going to be as successful as having multiple health societies come together. And I think the other one is I would look at the employers or talk to employers and say, well, how much are you spending on recruitment? Because recruitment is very expensive, and it's generally thought to be more expensive than retention. So how much are you losing by recruiting workers versus just retaining workers? And can you take some of that difference and help put that towards something like a housing subsidy, even if it's a rent subsidy? And those kinds of calculations, I think, are not done enough. I certainly couldn't point to you very easily recent papers that actually have even calculated out the cost of recruitment versus retention. So you certainly hear it from employers that they recognize that recruitment is much more expensive than retention. And so maybe one way to help retain workers is to figure out what that differential is and figure out, well, would you be willing to put some percentage of that towards helping your current workers afford housing so that maybe they'll stay in this industry just a little bit longer. And I think that's something every employer could spend a little bit of time looking at their books to figure out what that takes. Because recruitment is not just, just finding the person. It's the onboarding. It's the years of experience that you lose, when you have somebody who has retention, when you're addressing retention. And that is a harder thing to probably put a number on, is like, what is the dollar value of losing a worker that's experienced to somewhere? Because that is a very important value that I think is being taken advantage of very much
Okay, hello everybody. I'm Dr. Sean Berry. I'm a family physician and been practicing here in Oahu about 28 years now, and invited by Dr. Withy to be the moderator for the poster presentation. First of all, I'd like to thank all of you who put in the hard work to submit posters and your video presentation. I really appreciate your efforts and your scientific pursuits. I would just like to introduce my colleagues here, Dr. Vanessa Wong and Dr. Teresa Schiff, a couple other family physicians. So in the interest of time, because this room is going to be turned over for another event, part of our conference, but another event shortly after we're done. In the interest of time, we're going to let the videos play one after the other for about the first 8, and then we'll take a little break for questions. Okay, questions can come from any of us, including yourself or your peers or anybody out here in the crowd. So if you have questions, though, if you can jot them down and then remember which presentation it pertains to. Okay. Does anybody have anything they'd like to say before we start? Is there a hand up? No? Okay. All right. Well, thank you. And we'll go ahead and we'll do the first 8, and we'll kind of just let them roll through. Thank you.
Aloha. My name is Sierra Kame'ehonua.
Hi, my name is Michael Palepale.
We are 4th year undergraduate students at the University of Hawaii at Manoa. Our project today will be on Walk with a Doc.
Walk with a Doc is a place for communities worldwide to come together and improve their health. Having the opportunity to motivate individuals of any age to a healthier and happier lifestyle.
For our project, we experimented to see if people experience any benefits from walking. We also wanted to find the age group that doesn't incorporate walking in their life. We came up with a hypothesis stating that by incorporating walking into your weekly or daily life, it will improve your overall health and well-being. We created a questionnaire with 8 questions out of 40 points. The questions we asked have to do with whether or not the individual has mental, physical, and social benefits if they were to incorporate walking. The scatter plot shows the distribution of ages that scored below 29 and ages that scored above 30. The pie chart shows the percentage distribution of the scores with their respective ages. The blue portion of the chart indicates the frequency of people who scored above 30 points. The green portion of the chart indicates the frequency of people who scored below 29 points. This chart demonstrates that walking helps improve our overall health and well-being, having majority of the data scoring above 30.
In conclusion, we are able to prove that walking has many benefits and people who choose to walk experience them. From the data collected, our plan is to motivate and educate ages 10 through 40 to have an active and well-balanced lifestyle. Mahalo.
Hi everyone, my name is Elena Sun and I'm from Hilo, Hawaii. In my research, I studied mamaki tea, a native Hawaiian plant species that has been used by Hawaiians to maintain their well-being. Local farmers have seen more interest and consumption of it, but only a limited amount of scientific research has actually been done to provide scientific evidence to it. To connect modern science with this indigenous culture of mamaki tea consumption, I have focused my research on the various aspects of this mamaki tea in the past several years. I have studied its antioxidant, anti-cancer, and chemopreventive properties. And in this year's project, the main goal was to annotate metabolites in mamaki tea. So what are metabolites? Metabolites are small molecules and natural products, and annotating, in another word, is to identify. In this project, I was able to identify over 300 metabolites in mamaki tea using an untargeted metabolomics platform. This robust platform aims to profile the complete set of all metabolites within a biological system. Just to give you some ideas of how the research was carried out, first, samples of various concentrations and extraction solvents were prepared. Next, the samples were run through an LC-MS-MS system. The data was then analyzed using an MS style with a reference library, and MS Flow was then used for post-data curation. In conclusion, I was able to annotate 309 unique metabolites, with the most notable compound classes being prenolipids, which are known to produce laxative effects, coumarins and derivatives, which are used in the treatment of prostate cancer and leukemia, cinnamic acids, which can reduce inflammation and cholesterol levels and blood sugar, and strychnose alkaloids, which in low dosages can treat neurodisorders, arthritis, and vomiting. While this research is still ongoing, I'm continuously analyzing, processing, and refining the untargeted metabolomics data. I'm enjoying the process, and I hope you get to know a little more about Mamaki tea after this introduction video. Thank you.
Aloha everyone, my name is Alexandria Cole-Patino and I am a nursing student from Chaminade University of Honolulu and the student researcher for Period, Educate, Impact, and Perceptions. This research investigates the existing menstruation or period educations and their effectiveness as well as the perceptions of youth toward menstruation. So my personal experiences with menstruation led me to seek clarity on these two research questions. 1. How effective are the different sources and types of education provided to the youth relating to menstruation or period and management? And 2. What are the perceptions of youth about their menstruation or period? A literature review matrix was utilized to peruse through 20 pieces of literature gathered for this research. Data from the matrix was then analyzed through thematic analysis by highlighting key words relevant to the research, then organizing results into 2 theme tables that respectively pertain to each research question. Then, a checklist was developed using evidence from literature review to assess the effectiveness of 5 menstruation education sources randomly selected through a Google search. The table on the left conveys the 4 common themes on different sources and types of menstruation education. They are multimodal menstruation education programs, social media, surveys and questionnaires, and fact sheets. Multimodal menstruation education programs were supported by literature as an effective source and type of menstrual education. The table on the right is on the 4 common themes on perceptions of youth toward menstruation, which have shown to be advocacy and equity, a natural event positive, stigma, and a lack of knowledge. The prominent perceptions toward menstruation were shown to be stigma and advocacy and equity. The checklist analysis on 5 menstruation education sources demonstrates how menstruation education will generally either focus on teaching the physiology of menstruation or the management of menstruation. Recommendations beyond this research can involve refining the methods and expansion of this research study and examining the impact of Hawaii Senate Bill 2821, which concerns the statewide free menstruation products to be available to all public education campuses. Finally, a big mahalo to everyone for listening to my presentation.
Aloha, my name is Celia Chang and today I will be presenting on gout in Native Hawaiians in Hawaii. Gout is one of the most common inflammatory arthritic conditions, causing immense pain in various joints. Gout affects 9.2 million people in the U.S., and while it can be a manageable disease, it is often not managed properly, leading to excess healthcare costs and unnecessary visits, as well as greater morbidity, which is often seen in minority populations. And previous literature has shown that there is a difference in gout prevalence and treatment between minority groups and the Caucasian majority. Now, gout incidence is on the rise in the U.S. as well as in Hawaii. However, there is a lack of literature about gout prevalence in Hawaii, and there haven't been any real studies on gout in Native Hawaiians, so this study aimed to fill that gap. The objective of this study is to evaluate demographic characteristics, burden of disease, and hospitalization rates between Native Hawaiians and Caucasian gout patients. For this study, we conducted a retrospective chart review of 509 gout patients from 2011 to 2018, with additional methods stated below. We found that overall, Native Hawaiian patients were younger on average and had a younger age of onset of disease, as you can see in Table 1. We also found that Native Hawaiians had a greater median number of tophi associated with their gout, also seen in Table 1. Native Hawaiians were also found to use emergency services for gout a lot more frequently than Caucasians, which is seen in Table 1 and Figure 1, with the green line in Figure 1 representing ER visits, showing that Native Hawaiian gout patients visit the ED a lot more than Caucasians. And this trend seems to be increasing in the recent years, so we ran a logistic regression to examine this trend more closely and saw that in Table 2, we saw that Native Hawaiians are more likely to visit the ED for gout at least 2 times than Caucasians. We also looked at uric acid levels, which can be an indication of uncontrolled gout, and found that Native Hawaiians had higher baseline, mean, and max uric acid levels, as you can see in Table 3. So in conclusion, from the study, we saw that Native Hawaiians did indeed have a higher burden of disease of gout, as they had a younger age of onset of disease and had a greater median number of tophi associated with their disease. This means that Native Hawaiians are at risk for more severe gout and therefore may need better screening or preventative care management of gout than typically used in Caucasian populations. And overall, greater efforts may be necessary to foster culturally appropriate preventative care management of gout in Native Hawaiians in Hawaii. Thank you.
Hello, my name is Justin Abe, and the title of my presentation is Racial Disparities in Patient-Provider Communication in Oncology Telehealth Visits. Since the advent of the COVID-19 pandemic, telehealth has become increasingly more common in the care of oncology patients. However, it is not known if patient-physician communication via telehealth is equally effective among all racial groups. The purpose of this study was to compare patient satisfaction with communication during telehealth versus face-to-face visits among oncology patients, with a specific focus on Asian and Native Hawaiian and other Pacific Islander, or NHOPI, patients. We performed a cross-sectional study of a racially diverse group of cancer patients who had experienced a face-to-face and telehealth visit, and interviewed these patients using questions adapted from a previously published study, which assessed satisfaction with patient-physician communication. Asian and NHOPI patients were significantly less content with patient-physician communication during telehealth visits than white patients, even after adjusting for sociodemographic factors. For example, the degree of agreement with the statement, "Your physician listened carefully to you," was significantly lower among both Asians and NHOPI patients. In the center of the poster, I've included the 3 questions that had significantly lower levels of agreement among both Asians and NHOPI patients. If you go to the QR code under Additional Results, you can also look at Figure 4, which will show you the results of the multivariate analysis for the other survey questions. Importantly, you may notice that none of the odds ratio for face-to-face visits are bolded, which indicates that there were no significant racial differences in communication during face-to-face visits. In conclusion, the observation that telehealth increases racial disparity in healthcare satisfaction should prompt further exploration. While this was a descriptive study, future research should be done to determine if and how telehealth can be used in a more equitable way.
Hi, my name is Amanda Daniels, and I graduated from ASU in 2021.
And I'm Dr. Catherine Almer from UH Oʻahu and Integrated Health Hawaii.
We're going to be presenting Discovering a New Standard for Treating Depressive Symptoms. Currently, depression is ranked as the 3rd leading contributor to global disease burden. By 2030, depression is estimated to be ranked number 1. When it comes to addressing the needs of those with mental illness, collaborative care models are critical to delivering necessary resources. Care coordination is part of the medical home model that was included in Hawaii's 2014 Healthcare Innovation Plan, as one of 6 necessary catalysts to achieve the desired healthcare reform across the state. However, the standards of implementing care coordination services lacks empirical support. This study examined the effectiveness of the engagement-focused care coordination model at Integrated Health Hawaii on symptoms of depression. 7,969 care coordinators' notes of 208 de-identified patients were examined. Changes in PHQ-9 scores, which measures depression, was assessed across time. Measuring care coordination activities using the modified CCM tool was utilized.
Delivery of care coordination services was most effective using engagement-focused care coordination strategies, including parent education, multiple modes of delivery, and strategic engagement methods that went beyond the 3 attempts that are typically seen in care coordination models. As the graph shows, Patients who successfully enrolled in IHH's engagement-focused care coordination delivery system saw the most significant improvement in their PHQ-9 scores, which measures depression, going from typically severe or moderately severe to moderate or mild. So addressing a mental health crisis issues should consider effective solutions that ensure equitable delivery to diverse and underserved populations, and using collaborative care models can prevent unnecessary, costly services while effectively treating depressive symptoms. These are references, and thank you.
Thank you.
Aloha Kakao. My poster looks at the 3D ultrastructure of mitochondria in aging skeletal muscle. Well, it is known that skeletal muscle loses function across aging in a process now known as sarcopenia. The exact causes for this is unknown still. It has been hypothesized mitochondria are a main reason for this, but the mechanisms which govern their dysfunction are unknown. We hypothesize that the mucose complex is responsible for this structural change. To test this hypothesis, we used serial blood phase scanning electron microscopy alongside qPCR and a C-host analyzer. In figure 1, we evaluated mice which represented a 22-year-old human, a 50-year-old human, and an 80-year-old human. What we found is that in the older mice, mitochondrial morphology was fragmented and much, much smaller. Additionally, figure 2 shows that the networks of mitochondria were radically altered and reduced across aging. To evaluate the source of this change, we used qPCR in figure 3 to look at decreasing mucose transcripts as aging occurred. Additionally, loss of mucose complex caused reductions in oxidative capacity as seen in figure 3 and mitochondrial fragmentation as seen in figure 4. Together, this shows a similar phenotype between aged skeletal muscles and mice which are lacking the mucose complex, suggesting that over time the loss of mucose complex causes fragmentation in mitochondria. This makes the mucose complex an important potential therapeutic target in the future.
Aloha Kako, my name is Kristen Muto.
I'm Alex Muto.
I'm Reina Maglasong.
And my name is Blaise Babinek, and we are examining the specialist physician workforce resiliency during the COVID-19 pandemic. Hawaii has one of the worst physician shortages in the nation, and this has been an ongoing problem since many years prior. With an already delicate physician population, it is important to consider what impact external stressors may have, including the COVID-19 pandemic. In this study, we focused on 4 of the most in-demand specialist groups, which included cardiology, gastroenterology, pulmonology, and hematology and oncology.
So for our methods, we utilized the Physician Workforce Database, which was created by calling physician offices and hospitals. A full-time equivalent, or FTE, was calculated by taking the number of hours a physician worked at a specific location and dividing it by 40. Therefore, a full-time physician would have an FTE of 1. In areas where there was a physician overage, meaning that the supply was greater than the demand, the data was calculated so that there is 0 amount of shortage.
From the data in our results, we determined from our two-tailed t-test that there was no significant change, surprisingly, in the percent shortage in the specialists during the COVID years of 2019 to 2021 and our post-COVID in 2022 and previously before COVID started.
The reason why these findings are significant is because everyone assumes that because there's a huge shortage in Hawaii, our medical ecosystem can be very delicate and fragile. And we were very interested in how the pandemic, this huge, massive thing would have affected it. And a lot of us were expecting to find that a lot of the medical needs of some of the most remote communities in Hawaii were being unmet. Our findings are significant because we actually saw that throughout the pandemic, the physicians that were in the specialist roles that we were seeing, regardless on what island, stood their ground and were able to meet the needs of the community. So even though our medical community is small, it's very resilient and very durable to whatever can be thrown at it. This begs the question of why is there still a shortage? So future research can use our findings and build upon it to identify the specific factors that is limiting our physicians' population from being able to meet the full medical demand of people here in Hawaii. Mahalo for listening to our presentation. Thank you so much for having us here today and listening to our presentation. If you have any questions about our findings or how we conducted our studies or the wonderful organizations we're from,
please come see us at our Ignited Life table.
We'll be happy to answer any questions you might have.
Thank you.
Thank you.
Mahalo.
The purpose of the study was to determine the primary care shortage across Hawaii. Currently, there is an estimated total of 968.9 full-time equivalents of primary care physicians in Hawaii, when it needed 1,097 full-time equivalents, resulting in a 19% shortage among primary care physicians statewide when overage is not included. This study was done to help map where primary care physicians are needed and determine the shortage for each Hawaii, Honolulu, Maui, and Kauaʻi county.
The first method was supply. This method essentially helped us perform internet searches to determine where each physician worked and the preferred phone numbers to be contacted. By performing our phone calls, we were able to confirm their FTE or full-time equivalent status and their location. The second method that we used was demand. The demand model purchased by the IHS market in 2022 did not incorporate Hawaii as an island state. So, the demand data was split by islands based on population. Lastly, our final method was the study sample. What this did was focus on active primary care physicians who specialize in family medicine, general internal medicine, geriatrics, pediatrics across the state of Hawaii.
The majority of physicians are located in Honolulu County. The greatest shortage of physicians is on Oʻahu, followed closely by Maui, yet the county with the greatest shortage percentage-wise is Maui. From 2021 to 2022, the Oʻahu shortage decreased from 344 to 113.9. The Hawaii shortage more than doubled from 16 to 37.1. Maui increased from 32 to 45.8, and Kauaʻi increased greatly from 1 to 11.3. Statewide, the shortage increased from 163 to 208.1.
This map of the island shows the zip codes that have a primary care physician shortage in orange. When making this map, the supply wasn't based on FTEs, but on the number of active doctors in that zip code, meaning these areas may be experiencing a shortage, since not all doctors work full-time. But it is certain that the zip codes in orange are experiencing a shortage because one doctor cannot work more than one full-time equivalent. Statewide, all but 13 out of the 94 zip codes listed here have a shortage of PCPs. Looking back at the supply and demand of PCPs, even though there's a total of 968.9 FTEs out of 1,097, the statewide shortage is 208.1, which is larger than the assumed needed FTEs, as it does not include the overage of each specialty. This brings up the consideration of using family medicine doctors to help supply the general internal medicine need, since both serve the adult population. This can be seen in the Hawaii and Kauaʻi bar graphs, as there is an oversupply of family medicine doctors, which could help the general internal medicine demand.
There is a shortage of primary care physicians. This shortage is most prominent on Maui. The most physicians are needed on Oʻahu due to its large population, but other counties need a greater percentage of physicians to fulfill their shortages. The shortage of primary care physicians has been decreasing since 2019, but it is still very prominent and needs to be addressed. Some ways we can solve the shortages is educating the public on how to receive care. We can also work to bring more doctors to the island by creating more job opportunities.
Good afternoon, my name is Mahealani Lum. My partner Alex Zhang and I will be presenting our poster on the 2022 distribution of surgeons in Hawaii and the effect on surgical services. Hawaii undoubtedly is a paradise, but the price of residing in this beautiful state is immensely high. Inadequate reimbursement rates and high cost of living push doctors away from practicing in Hawaii. As of 2021, Hawaii County, Maui County, and Kauaʻi County are placed within the top 15 around the nation for the highest primary care worker shortages. The well-being of a community depends on a myriad of factors, and the amount of actively working physicians is one of the essential. Thus, it is of interest to investigate the population of physicians in Hawaii. This poster specifically focuses on surgeons. With the help of a group of volunteers, the active status of 566 surgeons with different specialties as listed in Table 1 were collected. FTE was utilized to standardize the measurement of surgeon workload.
The data collected consisted of active doctors and average FTE per zip code, as well as population in each zip code, with active surgeons present for the years 2019 and 2022. We then compiled the data and made comparisons. Based on the data collected, it showed that in 2022 there were fewer active surgeons and lower average FTE compared to 2019. The ratio of surgeons to total population was 1 to 2,790 in 2022, which is greater than 1 to 2,329 in 2019. Additionally, when looking at the comparative table, 3 zip codes lost active surgeons while only 2 gained. Likewise, there was an overall decrease in active surgeons and average FTE per zip code.
In conclusion, it can be concluded that Hawaii does not have enough surgeons. Additionally, as expected, most of the surgeons are found in Honolulu County, but there is also growth in the number of surgeons in other counties. Currently, to cope with physician shortage, specialists fly over to different islands a few days a week, and insurance companies offer inter-island travel plans for approved medical treatment. Another challenge that residents face is the long wait for an appointment time slot. Unarguably, Hawaii needs to recruit more physicians and specialists as well as decrease the cost of living. A possible solution is to increase the number of scholarships available to medical students that require service in return. Ultimately, it comes down to reducing the cost of living in Hawaii. This is not something that can be achieved in a short period of time, and to ensure the quality of healthcare in Hawaii, telehealth should be normalized. Hospitals in Hawaii should cooperate with doctors in the mainland U.S. to provide long-term telehealth service. This concludes the end of our presentation. Thank you.
Good afternoon. My name is Michael He, and I am a senior here at Athens High School. My poster presentation is titled Social Determinants of Health and Life Expectancy in a Sleep Disorders Population. Significant variations in life expectancy have been identified based on residence location, which has been attributed to differences in their social determinants of health. On Oʻahu, the Waianae region has the lowest life expectancy at 74.9 years. The east side has the highest life expectancy at 87.3 years. An additional region of long life expectancy on Oʻahu is the Pearl Harbor region. We compared the characteristics of Waianae region to the Pearl Harbor region, using sleep disorder characteristics as proxies for the social determinants of health. These proxies were age for life expectancy, race for racial issues, healthcare coverage for economic stability, BMI and neck size for nutritional status, medical comorbidities for overall health status, sleep apnea severity for severity of diseases, and CPAP compliance and 1-year use for healthcare compliance. We were able to identify significant differences in our sleep disorder patients' characteristics that correlate to their social determinants of health. The Waianae region were younger and had more Hawaiian and Pacific Islanders, had a higher percentage of Medicaid coverage, a higher BMI, less comorbidities, more severe sleep apnea, and poorer treatment compliance. These findings associated a lower life expectancy with indigenous races, economic instability, poor nutritional status, increased severity of diseases, and poor healthcare compliance. Our only outlier was the increased medical comorbidities in the Pearl Harbor region, which may have been attributed to their older demographic. The social determinants of health of communities underlies differences in their life expectancy. Understanding and addressing the social determinants of health is essential to achieving equitable life expectancy. Thank you.
Good afternoon.
My name is Raina Takaki, and today I will be presenting on the synthesis and evaluation of imidazole-bearing chalcones as a potential treatment for pulmonary aspergillosis. Our objective was to combine chalcone and imidazole moiety into a novel dual pharmacophore compound to test against 3 different pathogenic fungi. Aspergillus fumigatus is the main pathogenic agent of pulmonary aspergillosis, a spectrum of respiratory diseases that significantly impacts the lives of immunocompromised individuals. Unfortunately, some antifungal agents have become ineffective against the Aspergillus and Candida species, making it imperative to synthesize novel therapeutics. The chalcones were synthesized via the Claisen-Schmidt aldol condensation. The reaction was performed using an imidazole-substituted benzaldehyde and variously substituted acetophenones dissolved in methanol. Chalcone efficacy was evaluated against Aspergillus fumigatus, Aspergillus niger, and Candida albicans and compared to amphotericin B using 96 well diffusion assays. The assays were incubated for 48 hours at room temperature, and the absorbance was measured every 24 hours using a spectrophotometer. The results from the biological assays can be found in Figure 2, with Aspergillus fumigatus at the top, Aspergillus niger in the middle, and Candida albicans at the bottom. Higher absorbance readings mean that the fungus was able to grow and therefore the treatment was ineffective. The data suggests that the treatments had a significant impact on the growth of both Aspergillus species, but not Candida albicans. Furthermore, fluorinated chalcones are more effective than nitro-substituted chalcones and show promising results in comparison to amphotericin B. A possible explanation for the decrease in efficacy of nitro-substituted chalcones is that the high polarity of the nitro group makes the compound highly insoluble. The nitro-substituted chalcone was difficult to synthesize and dissolve into the biological assay, possibly making it difficult to cross a cell wall and membrane to act on the fungus. Future studies will focus on the synthesis of fluorinated chalcones. However, our next step is to synthesize triazole-bearing chalcones and to vary positive control treatments to assess the effectiveness of the synthesized chalcones in comparison to antifungal therapeutics of varying biological activities. I'd like to thank Dr. Bradley Ashburn and Dr. Helmut K. for their guidance and mentorship, INBRE and the NIH for funding this project, and the audience for listening to my presentation. Thank you.
Aloha, everyone. My name is Taylor Blondin, and today I'm going to be presenting my research on 3D alterations observed in mouse cardiac tissue across aging. Cardiovascular disease is the #1 leading cause of death worldwide, and we lack the therapies needed to treat it. Heart failure in the past has been linked to various factors such as oxidative stress, endoplasmic reticulum stress, and insulin signaling, of which mitochondrial functions are associated with. As the body ages over time, mitochondria decrease in efficacy as well as structurally, leading us to hypothesize that form follows function. Regulating the inner membrane folds of the mitochondria, known as cristae, which aid in ATP generation, is the mitochondrial contact site and cristae organizing system, or the Mecos complex. It regulates the changes in cristae morphology as well as maintains cristae junctions. It has been understudied in its role in cardiac tissue in the past. Therefore, we wish to explore it more. To better understand how mitochondrial morphology is affected across aging, we utilize TEM and SBF-SEM to analyze mitochondria in cardiac muscles in mice at 3 different life stages. These samples were taken from mice aged 3 months, 1 year, and 2 years, which are equivalent to ages 20 to 30, 38 to 47, and 56 to 69 in humans. As seen in Figure 1, we utilize 3D reconstruction to visualize these mitochondria at these life stages. As aging increases, mitochondrial area, perimeter, and volume decreases. In Figure 2, we characterize these mitochondria across aging and mitotype them to better understand how their overall shape changes with time. While sphericity was relatively unaffected, the mitochondrial branching index was. In Figure 3, we measured gene expression over time using 3 Mecos complex genes and OPA1, which has previously been linked to mitochondrial function. In Figure 4, we found that if we knocked out these genes, the mitochondria became fragmented, increased in fission, and decreased in volume and length. From the Seahorse analysis, we also observed that mitochondria significantly decreased in function when we measured the oxygen consumption rate. From this research, we now understand that the loss of the Mecos complex results in a change in mitochondrial morphology and therefore function. Perhaps the lack of Mecos complex proteins are responsible for alterations across aging. Thank you very much.
Hello all. My name is Rilla Bretz, and I will be presenting on behalf of the Emergency Medicine Group on our research project, It's All Connected, exploring the connection between physician shortage and emergency medicine demand. So, long story short, we came up with our hypothesis by reasoning that it is probable that a physician shortage of 20 to 50% across many different specialties contributes to medical care access barriers in Hawaii. And since we found research connecting a lack of access to care with a higher volume and severity of ER visits, we wanted to see if that was the case for Hawaii specifically. Therefore, our hypothesis is this: emergency medicine visits are higher where there are physician shortages, because we believe that emergency medicine demand is uniquely exacerbated by physician shortage specifically. So we use data analysis tests such as two-way ANOVA and regression correlation t-tests to analyze this connection. And our main findings centered around the fact that both physician shortage and emergency medicine discharges have been increasing for most specialties over the last 4 years. And there is a significant correlation between emergency medicine discharges and physician shortages in 2016 and 2019. And, as you can see, many of the discharges and physician shortages of the same specialty had similar trends. All of this supports our hypothesis that there is a significant relationship between physician shortage and emergency medicine demand. And while our results are preliminary, we think that they are definitely significant enough to warrant further research. Thank you so much for your time and have a wonderful day.
Good afternoon. My name is Vincent Uy, the head researcher of SingLab, a part of the UC Berkeley School of Optometry. I conducted my research on the short-term ocular biometric responses to different multifocal lenses. With previous studies, myopia or nearsightedness is now increasing dramatically across the world, and genetics alone cannot account for this sudden increase. Animal studies have demonstrated that the environment is also a factor in this. Myopia causes the lengthening of the eye due to eye growth. The lengthening of the eye is also associated with the thinning of the choroid. This is an important vascular tissue of the eye. Both the thickening and thinning of the choroid will cause ocular diseases. As a result, many eye doctors have commonly prescribed multifocal soft contact lenses as a form of myopia control. The purpose of this research is to investigate the effects of the two commercially available multifocal contact lenses on the eye's ability to accommodate, to gain a better understanding of the biometric responses to these lenses, which may provide further insight to their myopia controlling effects. A secondary aim is to correlate visual performance with lens fit in order to better understand the subjective effects of the optics on the eyes. My study design was a short-term, double-masked, randomized cross-trial of two commercially available distant center and near center multifocal soft contact lenses. We took the average data of all the participants who fully completed the study and went through all three trials who wore the two different lens designs for 30 minutes and 2 weeks after. We collected their biometric responses with measurements of visual acuity, objective refraction, near point of accommodation, pupil size changes, choroidal thickness, and axial length changes. After conducting our tests and analyzing our results, we found out that the near center lenses did not provide a larger change in choroidal thickness compared to the distant center contact lens designs, and we saw this through the t-tests, which indicated that the value of the differences between the two lens designs were not statistically significant, although participants who wore the near center contact lenses had a higher NPA value, or the near point of accommodation. All other anatomical measurements, including the end pupil size, actual length of the eyes, did not support the near center contact lenses role in providing larger change to this choroidal thickness. Hence, as a result, significant eye growth was not displayed during the 2-week incubation period of contact lens wear. For future directions, we may need to extend to a longer period of time in order to effectively visualize a distinct change in choroidal thickness or accommodation ability. Thank you for listening.